Okay, so at this time, good evening. Today is August 23rd, 2021, and it is 5:28 p.m. As a quorum of the board is in attendance, I would like to call to order the meeting of the Central Health Board of Managers. The first item of business is public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 3:30 p.m. today. Yesenia, did anyone register to make comments?
Yes, there is one member of the public who wishes to speak during this public communication, and I will now read the guidelines for this meeting's public communication. So when called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. At this time, I will call on our public input speaker, John Wagner.
Perfect. Thank you very much. Members of the Executive Committee and Board of Managers, my name is John Wagner. I'm a second-year student at Dell Medical School. For my first clinical rotation in obstetrics and gynecology, I saw the many ways that MAP and MAP Basic provide much-needed medical care to residents of Travis County. However, I also encountered the ways in which the program falls short, opportunities for the program to grow and improve. I'm speaking with you today to present a patient that I had the privilege of meeting while rotating with the gynecologic oncology team at UT Health Austin. For the sake of privacy, I will call this patient Ms. Smith. Ms. Smith is a 41-year-old female with stage 4 endometrial cancer and stage 1 endometrioid ovarian cancer. She was first diagnosed in 2017, and at that time, the cancer had already metastasized to her lungs. Over the next 4 years, Ms. Smith would undergo upwards of 40 doctor's appointments, 20 rounds of chemotherapy, and a surgery to remove her uterus, fallopian tubes, ovaries, and a portion of her abdomen. All of this was possible because of her coverage through the MAP program. Today, however, multiple cancerous nodules remain in both of her lungs, and despite the best efforts of multiple doctors and multiple teams, they continue to grow. The next step for her is more personalized and targeted approach called stereotactic body radiation therapy, or SBRT for short. The Comprehensive Cancer Network, the group that's responsible for providing standard of care treatment guidelines, indicates that SBRT is the treatment of choice for metastatic spread of uterine cancer. Additionally, the Centers for Medicare and Medicaid Services clearly outline that SBRT is the indicated treatment for tumors metastatic to the lung, liver, kidney, adrenal gland, and pancreas. SBRT allows for targeting cancer with high-dose ionizing radiation in a very specific manner that spares surrounding healthy tissue. SBRT has various advantages over more traditional brachytherapy, including improved sparing of healthy tissue, dose escalation without increasing radiation toxicity, and improved target dose distributions with very high precision. In metastatic uterine cancer, even aggressive treatment approaches using the more traditional methods, such as cytoreductive therapy and systemic therapy, are still associated with very poor outcomes, having a median survival of only 7 to 18 months. There is a tremendous need for patients to have access to more personalized approaches and specific treatment modalities. SBRT has been shown to improve progression-free survival and delay systemic therapy in patients with oligometastatic gynecologic disease. A 2020 study out of Johns Hopkins demonstrated that SBRT for oligometastatic uterine cancer provides both excellent local control as well as minimal toxicity, which is a huge step forward in the management of uterine cancer. Now, up to this point, Ms. Smith's coverage under MAP Basic has allowed her to receive the standard of care that was indicated for her cancer. However, neither MAP full benefit coverage nor MAP Basic cover stereotactic body radiation therapy. In fact, MAP Basic doesn't even cover any form of radiation therapy that's offered at Austin Cancer Center for gynecologic cancers. Now, Ms. Smith is left trying to figure out how to afford this potentially life-saving treatment or settling for less effective treatments that both go against scientific research and medical guidelines. Ms. Smith doesn't need some rare form of elective therapy. She needs the standard of care treatment that's offered for her cancer. While I understand that there are limitations to the coverage you can provide through MAP Basic as opposed to MAP, I ask that you avoid drawing the line in the middle of a person's standard of care treatment course. I ask that you include stereotactic body radiation therapy in future budget considerations for both MAP and MAP Basic. Additionally, I ask that you include radiation therapy at Austin Cancer Center under MAP Basic. Medically indicated standard of care treatment should not be withheld from people like Ms. Smith simply because of a line that was drawn in the sand. Thank you all very much for listening. Thank you for your time, and thank you for your consideration.
Thank you, and thank you for your service to our community as you have been embarking on your career. We will certainly take this under advisement. Thank you so much. Yes, Simi, is there anyone else at this time?
There is not.
All right, thank you very much. So members, I believe that we should start all of our meetings reminding ourselves of the commitments we all agreed to after our training that we had with Dr. Ramos Duffer this year. We all agreed to practice collaboration and accountability by following our agreed upon meeting procedures and ensuring all members had the opportunity for comparable speaking time. We also committed to intentionality prior to speaking, including considering, what is the goal of what I want to share? Is this the right time to share it? And is this in keeping with our collective goal for this particular moment within this particular meeting? We also agreed that if we do not follow these commitments, we welcome our board manager colleagues to bring this to our attention through the agreed upon process reflected in the commitments document. And when this occurs, we commit to immediately acknowledging the mistake and engaging in a repair and correction process. Additionally, the commitments document, which was signed by each board manager, and thank you managers, and all of the attachments to that document are included in your board packet. We will now proceed to the consent agenda. Consent agenda, item C1, approve the minutes of the Central Health Board of Managers, June 30th, 2021 regular meeting and June 14th, 2021 special call meeting. C2, receive and ratify Central Health investments for June and July 2021. C3, approve a contract amendment to the interlocal agreement with Travis County for cash management and investment services, risk and claim management, legal services, and television broadcasting. And C4, approve the appointment of Ms. Patricia Trish Young Brown to the Integral Care Board of Trustees as recommended by the Executive Committee. Is there a motion? Manager Bell?
I move that the board approves consent agenda items C1 through C4.
Is there a second? Manager Valadez? Okay. We have a motion by Manager Bell, a second by Manager Valadez. All in favor by signaling aye. Aye. Opposed, same sign. Abstaining, same sign. Manager Jones, are you abstaining? Okay, show Manager Jones is abstaining. Thank you, members. The motion passes. We will now move to the regular agenda. Item number 1, discuss and take appropriate action on a resolution of the Board of Managers of the Travis County Healthcare District approving the issuance and the terms and provisions and pricing of the district's certificates of obligation, approving the form of and requesting that Travis County Commissioners Court approve and adopt order or orders to authorize the issuance of such certificates and other related matters. Mike Giesel and Jeff Canoto and Blake Roberts, who is with our financial advisors, PFM, will be presenting. I will turn it over to them.
Thank you, Madam Chair. Thank you, members. I'll kick off the presentation tonight and then hand it over to Jeff Canotos. You'll advance to the next slide, please. So I'll quickly go over some of these slides before handing it off, but suffice to say that the bid process that we entered into at the end of last week and then concluded today went well for us. And so we are recommending that we go forward with tonight's and tomorrow's approvals with the Travis County Commissioners Court respectively. And that includes significant certificates of obligation for our Eastern Travis County project for Hornsby Bend and Del Valley. Next slide, please. as well as the Hancock Center, former Sears building, for administrative office consolidation and available clinical or flexible clinical space as needed. And again, this is administrative is at 90,000 square feet, approximately 100,000 square feet on clinical. And the reason for doing this project is so that we can achieve long-term savings on lease costs. And so by owning as opposed to paying rent, it's a significant savings, even up to the break-even period, but even beyond for Central Health. Looking into the future, let me say between the two groups of projects here, we have Eastern Travis County clinical expansion, and we also have the administrative office consolidation. Our priorities remain the Eastern Travis County expansion projects, so much so that we've got open procurements as well as permitting in place for the permitting underway for the Eastern Travis County expansion projects. But I thought that was important to restate what our priorities are for the community. Next slide, please. We include this slide to, again, recenter. You've seen it before, but it does a couple of things. It shows that obviously with growth in poverty in the Eastern Travis and the Eastern Crescent, as well as now you're seeing growth in poverty in the western northwest corner, but also continued concentrations of poverty, of families living in poverty right off the I-35 corridor. So with that, again, this justifies both our Eastern Travis County expansion projects, but also the need to have some centralized locations for clinical expansion, predominantly for what we estimate at this time to be specialty or subspecialty lines of services. Next slide, please. Here, I will hand it over to Jeff. Thank you.
Thank you, Mike. Jeff Knodel, Chief Financial Officer. The board has seen these slides. I'll go over them quickly. Just generally an overview of the projects. And I apologize, there is a typo on the Hancock facility size. It is 196,000 square feet. It is 106,000 square feet of clinical space. Between the two, excuse me, the three or really four facilities, we're adding over 125,000 square feet of upcoming clinical space expansions. As it relates to the financial information, and Blake Roberts with our financial advisor, PFM, will go over this in a little bit more detail, but just generally speaking, we're issuing contractual obligations with a term of 20 years, callable at 10 years. There is substantial savings long-term wise related to related to owning versus leasing. And when you own a facility, you also reap benefits long-term of both asset appreciation and equity from ownership, similar to what you would see home ownership versus leasing, similar concept. This transaction, this will transition our leasing costs, which is in our M&O portion of our property tax, to the debt service portion. And it also allows us to take into account favorable market conditions, including ongoing low market interest rates and Central Health specific Moody's bond rating, which is a AA2 rating. Next slide. This is a graph I've shown a couple times. It really just shows the analysis of leasing versus owning. And so there's a couple of attributes just to pay attention to. Leasing initially, as you look out from left to right over time, leasing does have lower cost initially. And that's simply because starting out on the owning or the building side of it, you continue to pay lease costs, plus you're paying debt service costs. But you'll see over time, as you service that debt, you see that the savings are achieved in this estimate at 15 years as a break-even net of lease cost, and that estimated savings at 20 years is about $17.5 million. And then substantial savings at 30 years, simply due to the fact that the debt is paid off and you own the building and you're not paying any lease costs. You're basically paying money to repair and operate the facility. Next slide. Just a quick comparison across hospital districts. Couple things going on this slide. It's a per capita comparison across the hospital districts. Debt per capita. On the left, you see our current per capita, which is $5. Our debt per capita of $5. And with this sale, these were preliminary estimates that we did a couple of weeks ago, so the numbers may be slightly different, but the projected amount is about $63 per capita in Travis County. Obviously, that compares favorably to other hospital districts that are much more capital intensive, and including on the hospital facility side. And then lastly, I would just point out that although Tarrant County has a fairly low per capita rate, they have approved an $800 million capital project to build a hospital facility. And so were that debt to be issued and project be completed, they would be comparable to the other districts in that calculation. Next slide. And then last, before I turn it over to Blake, these are the actions that we've taken related to these items, starting with both board approvals at Central Health and the Travis County Commissioners Court for the land acquisitions, for the building acquisition, and then project budget approvals at the Central Health level. And then we recently went to both Central Health and Commissioners Court for approval of the intent to issue contractual obligations. And then we're here tonight in the final step of approving the sale and issuance of the contractual obligations. So with that, I'm going to turn it over to Blake Roberts of PFM. He is the Central Health financial advisor, and turn the presentation over to him to go through the details of the transaction and the bids that we received related to issuing the contractual obligations.
Thank you, Jeff. Thank you, Board of Managers. It's good to be with you this evening. Next slide, please. So we are PFM financial advisors. Been the district's financial advisor for about 5 years now. And are very pleased to report on successful sale results from this morning. So Jeff described the process thus far very well. So over the past few months, the financial team of Central Health has worked in concert with its financial advisor and bond counsel, as well as David Duncan, to draft what we call offering documents to prepare the bond sale for bids for investors. That's been a multi-month process that culminated this morning with competitive bids that we took for the 2 series of bonds that were being issued. The first issuance of bonds was $62.755 million of taxable certificates of obligation to fund the Hancock expansion and admin consolidation. The second series of bonds was $13.63 million of tax-exempt COs to fund costs of medical clinics. The reason that there are 2 series being issued has to do with IRS tax purposes and the treatment of the use of debt. So any potential private activity use, leasing, et cetera, it's typically better to sell those as taxable for flexibility. So that's the reason that there are 2 different discrete bond series that were sold today. The award of the bonds, so who we sell bonds to is, in this case, through a competitive sale. It's a pretty transparent process. The low rate wins the bid. So that was how this worked this morning. And again, as Jeff said, The Central Health Board will consider the resolution this evening, followed by Travis County Commissioners Court to approve the bond order tomorrow. If these are approved, the bond closing is expected in September 21st, meaning that that's when funds will be delivered for the projects. Next slide, please. Just a bit of background on, well, right here, we're summarizing the first series, the tax exempt deal. So again, we sold 13.63 million in tax exempt bonds. You achieved a strong AA2 rating from Moody's. As part of the process, we had to solicit a credit rating. Each bond series was sold as a 20-year bond with a 10-year par call, meaning that in 10 years, you have the flexibility to either pay the bonds off if you have the cash or refinance the bonds at lower 10-year rates. The bonds are secured by and will be repaid from taxes levied by the healthcare district, and funding, in this case, the two clinics in Del Valle and Hornsby Bend. The bond purchaser on the tax exempt deal was Bank of America, and they provided you a very low true interest cost of 1.8%. So you're selling 20-year debt at a 1.84% rate today. For comparison, we're also the advisor to Travis County. The county sold 20-year bonds a few months ago at a rate of 1.75%. Now rates are a bit lower today, but just for some background, while you are a Travis County Healthcare District property tax pledge, investors typically will charge you a bit more because of the healthcare component. There's just a different risk profile and treatment having to do with healthcare. But that being said, after some conversations with bidders last week and education about what you do and who you are, we're very pleased at the rate you got. Next slide, please. So on the tax exempt deal, this is a summary of the bids that you received. Typically, anything more than 5 bids we view as a very robust demand. In this case, you received 7 bids. So the bidder name at the top, B of A Security, stands for Bank of America. Again, true interest cost bid of 1.82%. After we accept that formal bid, we do move some amortization around to smooth things out. So the actual final true interest cost rate will be a 1.84%. But for bidding selection purposes, this is how this was bid. So I want to be transparent about that. Next slide, please. This is a summary of your taxable deal, which is the bigger deal. And again, very good results here. Same structure overall, 20-year debt, 10-year par call, also secured by taxes. The winning bidder in this case was Raymond James. And if you go to the next slide, please. The summary of bids here, again, very strong demand. You received 8 bids. That's exceptional demand. Raymond James provided a low TIC at a 2.11%. Again, taxable interest rates are typically higher than tax exempt interest rates. So that's why you see a difference here between 2.11 and 1.84. But all things considered, from a historical perspective, rates are very, very low, and you did very well in the market today. Next slide, please. So this is a graph of Travis County Healthcare District's debt service on a going forward basis. I'll walk you through what you're looking at. On the left vertical axis, you have millions of dollars. And what you're looking at is debt service payments on the 3 series of bonds that you will have outstanding once these close in September. So the dark blue bars are your debt service payments on your 2020 refunding bonds, those refunded bonds that you originally issued back in 2011. The orange bars represent principal and interest payments on your tax exempt bonds you sold today. And your gray bars represent principal and interest payments on the taxable COs that you also issued today. So this is the debt service that is, as Jeff said, is being shifted from some of the O&M part of your budget to the debt service tax rate. Next slide, please. Interest rate trends over the past few years. Again, this graph is a little bit colorful. What it, I think, shows is sort of the rate movement over the past 2 years. The spike that you see is the beginning of the pandemic. What you see is that there was a very sharp increase in rates, and essentially the market shut down during the pandemic. Since then, rates have gone down, then back up, and gone down again recently. So in the last 3 months, just for example, the 10-year Treasury rate was as high as a 155, 160. We were today at a 120. So better to be lucky than good sometimes. But in today's market, we were at a very, very low rate environment. So that's good. Next slide, please. Lastly, I'll visit with you a little bit about the credit rating. You received a AA2 rating from Moody's. This is a new rating that we solicited. If you recall, back in 2011, you were actually AAA. Well, so why are you different from AAA? Well, there's a few reasons for that. In the last decade, rating agencies have begun to take a more focused view of the healthcare and the hospital district sector, and have begun to treat the risk in that sector a bit more into their ratings. And so they don't just look at the overall economic base of Travis County and the strength of just the tax base. They also factor in hospital operations and how the healthcare sector operates generally. So we thought a lot about how we approach the rating process. Ultimately thought that Moody's gave you the best chance for the highest possible rating. So you received the AA2 from Moody's Stable Outlook. That reflects a few things. One, Moody's commended management, and that reflects the board as well. The strength of the reserves, the conservative budgeting practices, the things that Jeff and Mike and his team do and the board oversees as it relates to budgeting and conservative budgeting. Liquidity was important to the level of cash reserves. Again, the large tax base of Travis County, that certainly speaks for itself. The economic factors here, the considerations, sort of the negative factors that they looked at were the health insurance plan, the capital requirements that are ongoing there, and then federal revenue uncertainty. Nothing really specific to Central Health. I think these reflect general sector views from Moody's on the healthcare sector. But all in all, a really positive rating report from Moody's. Next slide. And I think that actually concludes my formal remarks. So again, I'll close by saying, last week we began conversation with potential bidders. Really weren't sure where we would end up. There was a healthcare district deal that priced last week in Midland County. Watched that very closely. Very pleased to say that we outpriced that deal this morning. That's always a good thing. And you were close to pricing on Travis County GO bonds from earlier in the summertime. So we do think this was a good result for TCHD this morning, and I'm certainly happy to answer any questions of the board may have.
Thank you very much, everyone, for that presentation. And certainly I'm very pleased with those rates, and being that close to Travis County is, I mean, we're really virtually the same. So thank you very much. And I know some folks who are watching this may wonder why the rate was a little higher on the series that is taxable. And we had to do those taxable because there could be some what we call private activity to that. It's an IRS, and I won't get into the weed with it, but IRS regulations. But the point being that you always pay a little more in interest when it's taxable, because those people who are buying it do not have the advantage of it being tax exempt for them as investors. So you're always going to have a little higher investment rate on the taxable. So I think we did exceedingly well on those too. Thank you very much. Anything else at this point? Manager Jones. Manager Jones, did you have something?
Yeah, I have a couple of questions. We had several presentations there. So should we take them all at one time or just the latter one? I
think, Mike Giesland, is there anything else we need to cover this time, or should we just open it up to questions?
Not at this time. Please open it up to questions.
Open it up to the questions that you have, Manager Jones.
Okay, the first question goes to, I'm sorry, our expert in terms of the financing of our bonds. My question was, we're at AA2 as a Travis County healthcare district. How do we rate compared to some of the other ones? Can you speak to that at all?
Yeah, sure. It's a great question. You're very comparable. We looked at Bexar County Hospital District, Harris County Hospital District, and in Dallas County. Bexar County and Harris County actually have a one rating that's equal to yours, and then one rating that is a notch higher. And what I would say is that really has to do with them being more frequent borrowers. They have a lot more debt, which is not necessarily a good thing, but you're an infrequent borrower. And so I think that given the lack of a track record in the capital markets and just not having familiarity with Central Health, they certainly commended the financial aspect of the district, but there were some questions around federal revenue uncertainty. What does that look like? There was the capital requirements for the insurer, and just getting their arms around sort of what to them credit. I think they came out at a slightly different rating at one notch lower. That being said, where rates are now, being one notch below Bexar County doesn't really affect your ultimate pricing. And I think that if you're in the market more frequently, there is the ability to sort of visit with them more often and have that track record. But to directly answer your question, you're very comparable to other major urban hospital district systems.
I would say comparable or better. This is an exceedingly good rating. And given that they are not familiar with this, and that difference in a rating is not going to make the difference in the interest rate that we get, as Blake said. Another question, Manager Jones?
Yes, the second part of the question, and thanks very much, that was very helpful, I appreciate it. You mentioned, I think in your presentation, is the hospital part of the hospital district in terms of owning hospital, running and operating them. Given we don't do that, does that have any impact in terms of our rating at all?
I'll defer to Jeff on that a little bit, but we took a lot of time with Moody's to explain and delineate that. And I do think they walked away understanding that. So I don't want to misspeak and tell you that them believing that you own a hospital was the reason your rating was what it was. It really has to do just generally with, again, those two key pieces: federal revenue uncertainty and the capital requirements for your insurer. So I don't know that the hospital risk per se was a direct factor, but it certainly, anytime healthcare is part of the equation, there is risk that is viewed as sort of above and beyond just a typical general government profile, for example. And they begin to ask what would happen in the event that the system began to have financial challenges, and what would that look like? So that's the sort of more existential risk we're talking about. But it is a good distinction that we certainly tried to impress upon them, and I think Jeff was very successful at that there is a difference between Travis and others, and that you don't directly operate that hospital.
But again, they're going to err on the side of caution always, and with them not having experience with us previously, that's to be expected.
Okay, that was very helpful. I'll save my other questions, most of them related to the facilities too, when we start talking about those questions.
Okay, managers, other questions at this time? Manager Valdez, did you have a question?
On what Manager Jones asked with respect to, you said, Blake, thank you for your presentation, and Jeff, with respect to the fact that they looked at our federal, I'm sorry, did I understand you to say federal instability? I'm under.
Let me interject. I don't think instability was the word was used. I think it was just.
What exactly was the term that you used?
I think the term that was used was federal funding uncertainty.
Okay, federal funding uncertainty. The reason I asked that is because what were they looking at? Were they looking at the fact, since the hospital has been in existence for a long time, and we've been in the central healthcare district business since 2004, why would they think that the federal landscape was a little bit uncertain? Were they looking at the change perhaps, or did they not understand what DSRIP meant? Was that a consideration, or the fact that, we have a private-public relationship and that we provide dollars to these hospitals? I mean, where did they get the fact that there is a possibility of uncertainty? Because we're providing revenues, we're paying for expenses based on property taxes, not necessarily so much so on federal income.
So let me address that. So generally speaking, there have been a lot of changes in federal funding programs, whether it's the source of funding, whether it's the renewal of, for example, the 1115 waiver.
That's what I asked.
The approval and possible, I'll say possible, rescission of forward-looking programs as far as the extension. There's just a lot of uncertainty of what future funding looks like. It's not necessarily that it's going to go away one day. It's just the nature and solidifying of certainty over a long period of time. And I think just the change in volatility of healthcare federal funding programs is just a factor that it's just the nature of all of the healthcare entities that is part of what we have to deal with on a year-to-year basis.
That's right. I would add the rating agencies have criteria for different types of entity, right? And so don't take it, quote, personally. If you're a healthcare entity, they're going to apply certain criteria to everyone. And they're also going to say, oh, we think that, a general obligation in general of a city or county may be higher, quality than a healthcare district. So they have criteria for different types of entities and bonds, and they're going to apply them.
I get that, Sherry. Thank you very much. And thank you, Jeff, for that good stab at it. Blake, is there anything else you wanted to offer? Because it sounds to me like they weren't necessarily familiar with our type of funding setup, but I just wanted to clarify.
I'm just going to interject here. I don't think there's anything else, Manager Valdez.
Okay, thank you. I just want to make sure. Thank you. That's why I was asking, since he was the one that provided the report to us.
Yeah.
It's got PFM on there. I just wanted to.
Yeah. Blake, was there anything else that you wanted to add at this time?
No, I think they describe the federal revenues and it certainly is in their report. It's just simply their view. I do think they walked away understanding how the flow of funds works. I think there was just a different opinion in terms of the risk profile of those revenues versus the experience we've had.
Thank you.
I would also add that any hospital district in Texas that was going out for debt issuance would probably receive the same comment regardless.
Exactly. It's just their criteria and they're going to apply it. Manager Jones, did you have something else?
Yeah, so I want to know what action item, if any, we're going to be taking with regards to this presentation, because I do have some comments regarding the bids the obligation bonds. And so I wanted to have some comments before we vote on that.
So if nobody else, does anybody else have any questions? If not, we'll move on to Manager Jones's questions because this will be an action item. Manager Valdez, did you have anything else before we
just one last thing with respect to that before we get to the actual vote? I'd like to know if we can vote on these as two different sets of different votes, one for the taxable and one for the non-taxable. Because that's my request. That's my request.
I understand your request. David Duncan, I'm looking for you here.
It is my understanding Manager Valdez, that it's a single issuance, that there are two different instruments, but, and I'll look to Jeff or Blake to correct me.
Jeff, do you want to respond to that, please?
I will let Blake or bond counsel respond to
Blake?
that. I do not think we are able to do that. It's my perspective on it, but I'm not a lawyer. So I will.
Blake, can you respond to that, or do we have bond counsel present?
As that one is a taxable, one's a non-taxable, I'd like for us to be able to have a vote.
Yeah, we understand the question.
Thank
Blake,
you.
Can you
Yeah,
respond? Or
I
do we
mean,
need
from my
bond counsel?
perspective, these are discrete bond issues. So I don't give a legal opinion, but these are discrete bond issues. So if there was a desire to award
Separate them?
one or not one, yet not the other, I mean, I think you can. I think we were voting on two separate bond issuances.
Thank you. Then I'd like to make a motion.
Wait a minute.
But
we're not ready,
I'm not giving legal advice. I want to
No.
be abundantly clear.
Our bond counsel is not on.
Okay.
And I told her we might need her for,
Can you-
yeah, let me see give me a moment and I'll see if I can get her on.
And do we need
Maybe
to?
if you want to talk to Manager Jones.
Yes, we're going to go to that. Thank you, Manager. Manager Jones, can we address your questions while we're getting bond counsel?
Okay, yes, I just want to be clear on what we're being asked of. Well, the first question is, I know this has nothing to do directly with this, but are we still proceeding on our Colony Park facility, working with the city on that?
I think we have another agenda item on Colony Park. Is that
okay,
correct?
then, well, I'll say that for later.
Yes,
But-
correct.
We have
Okay.
another agenda item on that,
Okay.
Manager Jones.
Well, then my other question relates to the process by which we go ahead to purchase the land acquisition for the central administration building, and the time frame in which we complete the construction or begin the construction and complete on the two facilities in the eastern part of Travis County. I'd like to see where possible we can prioritize and give direction that construction be completed, or at least 75% completed, before we begin any work on the central administration facility. The thinking being is it would not be appropriate, in my mind, to be building a new central administrative building, even though I'm extremely supportive of it and think it's necessary, when we still have not, but we have not completed the construction of these facilities in the Eastern Crescent.
Mr. Giesland, do you want to address that question?
Well, really, it's a question back to Manager Jones. If what you're talking about is the actual construction process, I think there's a high likelihood that that's going to happen naturally. But if what you're talking about, for instance, is not procuring necessary architectural and engineering services before you see any bricks being moved out of the Sears building, so that let's call that preliminary work or maybe back office work for sake of conversation. So if you could clarify, what you mean by work, that would help us answer your question.
Okay, thank you. I'm in favor of us doing what's necessary to purchase and acquire the land. I have no problem with that. I think we need to and should. I am concerned that we proceed, that we should begin purchasing the land, developing designs and the like, while we're having facilities still sitting in Eastern Travis County that are gradually but slowly being built, but by no means will be complete by the time we've 50% our way with the central administration. So I'm trying to build into this vote some way to ensure that those facilities are completed before the central administration building is even, before it's begun construction on it. That doesn't prohibit the design and everything, but it does prohibit the construction.
Well, what I would recommend is that, since tonight's vote is about the certificates of obligation, is that we bring back a separate agenda item that discusses these timelines. And then that way the board has a chance to
Chime in.
digest the issue and properly deliberate it. But then getting to the point where you're taking that vote to provide those instructions, and you've got full line of sight into all the related costs and carrying costs and so forth.
Thank you.
And I appreciate that. My only concern is that what assurance once we do that will occur.
That it comes back as an agenda item?
for action?
We,
You just put it on the agenda per
Yeah,
the
I
call
can
of the
just-
chair. I mean,
Manager Jones, I could just put that, and I will put it on the agenda as an item for us to be briefed on and take action on, okay?
Would that ensure that that priority that I mentioned give precedent over the action?
That will be up to from what I'm understanding from Mr. Giesland, staff will give a presentation, and then it will be up to there will be an agenda item, and then there will be an action item, and it will be up to the board will have to vote on it. So it depends how the majority of the board votes, is my understanding. Is that right, Mike Giesland?
yes, that's correct. And but also just if I may, just one quick aside is that publicly, by virtue of this meeting and also prior meetings, as well as our community conversations, have been very clear that our priorities are the Eastern Travis County Clinic expansion.
Absolutely.
projects.
Our number one priorities are those Eastern Travis County clinics. You're
I know
absolutely
that.
correct.
I'm just saying is that I'd like, as a board member, to somehow
Right.
be able to codify that in writing, either by a vote, to ensure that that happens. Because once we begun that acquisition of
understand.
land purchasing, there's nothing to assure that that will not jump to the front of the line.
So we're going to have to bring back an agenda item. I will work with staff. We will get an item on the agenda with, full backup and briefing. And then my understanding is there will have to be a motion and a vote by the board. David Duncan, I see you have reappeared.
I have unfortunately been unable to reach our outside counsel. I've tried her cell phone and I've tried her office phone, and I texted her and sent her the link for the full meeting, and I have not seen her join yet. So I apologize. She said she was going to be on call, and Jerry Kyle, who's the lead counsel, the partner there, is out for a medical issue and can't join us tonight. So Taylor, I've been trying to reach Taylor and have not been able to. So if you'd like to wait on this item or come back to it, we could do that. Oh, wait. No. Sorry.
Did you have anything else? Okay. Manager Jones, did you have any more questions before I go to Manager Valadez?
Hey, I'm sorry to interrupt. I do have
Yes,
another
Mike.
on the phone. So I just give me one.
You're on the phone with who?
With bond counsel. Give me
Oh,
just
good.
one second.
We need bond counsel here, don't we, David? You need to tell bond counsel
Yes.
to get with David and get here now, please.
While they're doing that, I guess my question, I would just make sure everyone, is it clear what I'm asking for?
Yes,
Yes, it's very clear. Understand it. It's very clear. We'll get with staff. We will have an item on the agenda. Staff will present it with backup. There will be a motion that the board will then need to vote on. Manager Valadez.
yes, ma'am. Thank you very much. Manager Jones, that has been my concern since we took the original vote. I support this, the probability of this coming up as soon as possible. However, I'm concerned about the fact that we didn't even include the sale of our current location. And I think that needs to be a part of the discussion when we're talking about financial and fiscal
I understand.
protections. But I do not want work to begin on this while we still have 3 commitments to our Eastern Crescent residents that we were going to build these clinics. That needs to be done first. I have seen commitments made before and they didn't happen.
So Manager Valdez, I understand this item will be on the agenda and brought back.
I appreciate that. I just wanted Manager Jones to
Understood.
this is where we're at.
Understood. As far as the sale of a current building, staff was being very conservative on our projections. And so staff did not put in there the sale of our current building, which would have made the projections even better. I'm sure that staff would provide, and I'll put this to Jeff Knodel, a less conservative projection for us that would include the possible sale, looking at our crystal ball of our current location. Jeff, I'll put you on the spot here.
Yeah, you're absolutely right, Chair Greenberg. We did not factor in any sale of any locations related to the savings. So, but if we had factored that in, the savings would have been much greater.
That's right. So maybe you can bring back something that has kind of a range with your crystal ball range of what, you know, a sale would be. Is that possible, Jeff?
We can work on a future meeting to
Yeah,
look at
That's
that.
exactly, I am certainly
Sure.
talking about in a future meeting. David, I see you have reappeared. Do we have bond counsel?
Yes, ma'am. She's on the phone. It's the
Okay.
4170 number, and she's going to be unmuted
Hi,
right
Taylor
now.
Raymond.
I can't hear you. Can you either get closer to your mic or something?
Hi, can you hear me?
Yeah, it could be louder, but go ahead.
Hi, this is Taylor Raymond with Orrick, Harrington, and Sutcliffe.
Do you have earbuds in or something you can take out? I can see that members are having trouble hearing you.
I do not, but let me see. I dialed in from my phone, so let me see if I can
Turn up the volume on your phone or something.
do it on my computer.
If not, just shout and we'll hopefully be able to make do.
Okay, I'm trying to join in from my computer, but generally that's not any better.
Okay,
So
what
let
you're
me
doing now is a
try to-
little better, so just shout.
Okay. Okay, I can shout.
Okay, so
I
ma'am,
Well, hold on, Manager Valdez. Okay, so the question that was put before.
I was going to ask the question directly.
Okay, Manager Valdez, go ahead.
Thank you. I appreciate that, Madam Chair. Yes, bond counsel, Madam Chair has been very, very considerate in allowing me to ask this question. I wanted to know if it was possible to have two distinct votes. One, to separate the agenda items so that one is a vote on the taxable component of the sale of the CO bonds, and the other was having to do with a separate vote on the non-taxable certificates of obligation bonds. That's my question. And if there's
Yes.
is it a possible, can we do it that way?
Yes, that is a possibility. We can revise the resolution and we can separate the resolution out. So there are two separate resolutions. One is for the tax exempt and one is for the taxable. And it would be pretty straightforward. If you can see in the resolution, it just has orders with parentheses S, and those would just become one for the tax exempt and the other resolution would be for the taxable.
So if that being the case, then I would like to make a motion. I'd like to move in support of the non-taxable certificates, sale of certificates of obligation for the clinics.
Manager Valdez, we may need new language. I want David Duncan and our bond counsel. Do we need some kind of new resolution in official language?
It would be necessary once we're all said and done, but I think if we take the votes on the board's direction on the two issuances, then we could actually do the formal motion that was included in the backup.
Okay, just, sorry, Major Valdez, I want to make sure.
Depending on the outcome of that, we may have to go back and revise the resolution.
Okay, go ahead, Manager Valdez.
So I'd like to move approval of the certificates of sale of certificates of obligation for the non-taxable component to fund the construction of the clinics in the Eastern Crescent.
Is that wording sufficient, David Duncan and bond counsel? Or do we need to revise that wording?
For the current purposes, I think the question I think is going to be whether you ultimately approve both series. And if you don't, then we would need to go back and revise the resolution and probably come back to you later in the meeting.
Personally, I don't think that's going to be an issue, but
okay.
Can we take the vote?
We had a motion. Is there a second? Manager Musaitis? No. Manager Jones?
I have a question.
Well, let's do a second and then we can open it up.
Second.
Manager Jones, were you seconding? Yes? Can you unmute, please?
Yes.
You're seconding?
Yes, I will second it.
So we have a motion by Manager Valdez. We have a second by Manager Jones. Now, any questions or discussion? Manager Musaitis, did you have a question?
Yes, can someone clarify to me what is the purpose of separating the two?
Well, by separating the two, you're going to take two separate votes.
That's right.
Yeah, what is
That's
the
what's going to happen.
purpose of separating the two? I'm just trying
The
to.
purpose is for intent of each individual manager for the public to know how each individual manager is voting on the two different certificates of obligation. If you want it all to be contained in one motion, you are not allowing us as managers to be able to vote on each separate one. I am for the sale of certificates of obligation on the non-taxable amounts. I am not for or would like to appreciate the opportunity to abstain on the taxable certificates of obligation. That is why. And since
Manager Masako, does that answer your question?
It does, but I don't appreciate the tone. Thank you.
Thank you. Okay.
There's no
Any other questions at this time, managers? Okay. If there are no other questions at this time.
Call for the vote.
Yep. Okay, so we will go ahead and vote. So all of those in favor of the motion signify by voting aye. Aye. Okay, any opposed? Signify the same sign. Any abstaining? One abstaining, Manager Bell. Okay, the motion passes. Do we have any other motions, members? Do we have any other motions? We have a separate set of, yes, Manager Valadez.
Madam Chair, I'd like to know if I make a motion, I don't necessarily have to vote for it, correct?
Correct.
Okay, I'll move for adoption of the sale of the certificates of obligation for the taxable component.
Is there a second? Manager Bell, are you seconding? If you could unmute. Okay. Yes. Go ahead and unmute.
Yes, I second it.
So there is a motion by Manager Valdez. There's a second by Manager Bell. Any discussion? If no discussion, we'll go ahead and vote. All those in favor signify by saying aye. Aye.
Aye.
Any opposed? Same sign. I'm showing Manager Valadez opposed. Any abstentions? Okay, thank you, managers. The motion passes. All right. We will now move to the next item.
Madam Chair, in
Yes.
light of the approval of both series, I
Yes,
would
sir.
appreciate if a member could read the motion that was so carefully crafted by our outside counsel.
Manager Bell, do you have that in front of you? The
I
original
do.
motion?
I do. I move that the board approve a resolution for the Board of Managers of the Travis County Healthcare District provided in the backup materials, and you were sent this just recently via email for this meeting, approving the issuance and the terms and provisions and pricing of the district's certificates of obligation, and approve the form of and the request that the Travis County Commissioners approve and adopt orders to authorize the issuance of such certificates.
Thank you, Manager Bell. David, Duncan, and Bond Counsel, do we need anything else on this item?
Just to vote on that motion, ma'am.
So we're now going to vote on this motion. Okay, is there a second to this motion, members? A second. Manager Brinson. So we have a motion by Manager Bell, a second by Manager Brinson. All in favor signify by saying
I have a question.
Yes.
Just a real quick question. By voting on the resolution, am I voting for both sales?
This covers both series. Yes, ma'am. It covers
Okay.
both series.
So then you put me in, that was my concern. Then I'm put in the position of ultimately, why do we go through this exercise? Because I would have to be voting for, not only now for something that I voted against or would have abstained from, but I'm also voting against something I voted for. So I wanted to know if there's better language that can incorporate the intent.
I understand, Manager Valdez. That's why I was asking David and Bond Counsel if we needed to have different language.
Thank you, Sherry. You got it exactly right.
two separate resolutions. What do we need to do here, David and bond counsel?
I'm trying to figure out how to capture this, because at the end of it, both series received a majority vote. And I'm not sure. So the purpose of this is to send something to the Commissioners Court for their approval.
Right.
Correct.
And I don't know how you're going to send something to the Commissioners Court for their approval and say, but a couple members voted no on about a third of the debt. I just don't practically understand in terms of just majority voting and the way Robert's rules works and the way our process works. They can read the vote tallies for the two sub votes, but this item is, we want to send this to the Commissioners Court for their approval.
Right.
And since both halves of the issuance have already been approved, this is really just the formal act of sending it to the Commissioners Court for their approval of the items that they've both already been voted on. They both passed with a majority vote.
So is this similar to the executive committee approving something of our board to go forward to the full board? Is that what you're saying, David?
Similar to that, yes.
Okay, Manager Valadez?
Yes, I have a question, David. As our legal advisor, is it possible to put in there that I'm just wanting to know how can we preserve how do you preserve the intent of a no vote or even an abstention? I know that the majority voted, but the first vote, the non-taxable vote, got a unanimous vote. The one that did not was the second, which is the taxable component. Is it not just possible to include that in the resolution? Bond counsel, or you, David, or bond counsel, is that something that can be done? Has that not ever happened before?
Okay, Manager Valadez. Manager Bell also, it looks like, has a question. Manager Bell.
It's not a question. What happens is we're a body, all right? We
Right.
voted,
I understand that.
all right? And there is documentation that you, Manager Valadez, voted against the non-taxable. So now we want to send our decision as a body to the Travis County Commissioners. That's what this motion is about.
Exactly. That's what I'm saying. It's similar to if the executive committee votes, it may be that not everybody voted for it, but the executive committee sends something forward to the full board. So is Manager Bell, do you want to take an action here?
No, I just want somebody to second my motion and move on. That's
Okay, there was a second.
It was already seconded.
It's already seconded by Manager Brinson.
Then
Are you
call the
calling the
question?
Okay. Manager Bell has called the question. I will call the vote. All in favor signify by saying aye. Aye.
Aye.
Any opposed, same sign. Any abstaining? One abstaining. Record will show Manager Valadez. Thank you, members. The motion passes. We will now move to agenda item number 2. Receive and discuss a report on fiscal year-to-date healthcare service expenditures made by and accept the preliminary June and July 2021 financial statements for Central Health and the Community Care Collaborative, and review historical average revenues and expenses for Central Health. Lisa Owens will be presenting, and I will turn it over to her very capable hands.
Thank you. Good evening. Due to the timing of our meetings, you did receive the June and July financial statements. However, in the spirit of the current month, I'm going to focus on the July financial statements. So if we can start, I believe, with, sorry, let me get my screens right, Central Health. So I'm really going to focus on the highlights of major transactions, and you will see a theme that was the DSRIP program IGT. We did transfer that $19 million. You'll see that on the highlight slide there for the CCC DSRIP program. If we can go to the next slide on our assets, at the end of July, we still had a strong cash position. We had current assets of $322 million. And as part of the restricted local provider participation fund, LPPF, we had $38 million due to the timing of some quarterly funding requests. Our capital assets were at $69 million and our total assets were at $552 million. We can go to the next slide. On our liabilities, they do remain low. Our total liabilities were 58 million. The current liability is at just $14 million there. And then our total net assets, very stable at $552 million. Looking to the sources and uses on the next slide. Our property tax revenue, as you will recall, at this time of the year, is the collection is quite low at this time of the calendar year, as those taxes were due by January 31st. So we had some timing differences with prior year refunds, but that negative dollar does go into the total year to date of $237 million in property tax revenue. As I mentioned, on our healthcare delivery slides, we'll talk about those in a little bit more detail next. We did have $28 million in healthcare delivery this month, and year to date, sources over uses was $280 million. If we can go to the next slide. Again, the highlight here being that due to the timing of the annual IGT that we make for the CCC Desert program, we did transfer those funds in July. Those were at 19 million. And although it looks like it's under budget, it did result in the same dollars to the CCC for their programs. They had wonderful results. We'll talk about that on their program. But due to COVID, we still have an enhanced matching rate. And so by transferring fewer dollars, we were able to bring the same amount of dollars into the CCC Desert program. And then in our primary care and specialty care, we had very standard months. We continue to be tracking a little bit behind in our utilization, as we've talked about in previous months, but another stable month of healthcare delivery costs at $5.4 million, as well as in our ACA program, and total healthcare delivery again at $28.2 million. So with that, I'm going to stop and answer any questions on Central Health, or I can keep going on to the CCC. I'll keep going. Brianna, if you could switch to the CCC, that would be great. Thank you. Oh, go back just a little bit. Great. So in the CCC, on the next slide, again, we saw a big jump in our cash this month as we, on the next slide, one more, on our receivables this month. I'm sorry, I think this is June. If we could go to July. Okay, thanks. Okay, there you go. We did receive the DSRIP revenue for the program. We had a timing difference on one of our receipts for one of those. It came in. So you'll see a receivable there of $8 million. That was cash that was in transit that happens time to time at month end. We had total assets of 68 million, predominantly cash, and then a receivable that came in August 1st. Our liabilities include our payment to UT as part of the UT affiliation agreement. That payment was made in August, so we record that, as you'll remember from previous years, as a liability in July. Also to note, as we look at sources and uses on the next slide, we do have deferred revenue, and we've talked about this a few times, that we're under a continuous routine audit for the DSRIP outcomes, and we work closely with the healthcare delivery team to reserve some cash that we've already received in the case that we did have any measures that upon review by their third-party consultant, we would have to pay back. So that's why here you'll see it looks like we're under budget in DSRIP revenue, but in fact, the cash position shows that we did receive the cash. We're just reserving some of that as we're in a 3-year period of that routine outcome review through the DSRIP program, which has been in place throughout the program. On our healthcare delivery, if we can go down to the uses, we did have $11.2 million in healthcare delivery. I'll hit on that on the next slide, but we did, again, as I mentioned, make the UT services agreement payment in August. You'll see that recorded there in July. And then we estimate our DSRIP project cost to our 3 performing providers to be about 9.6 million. So net sources over uses at about just under $15 million and total net assets at about just under $20 million. So the last slide, again, healthcare delivery costs predominantly in the CCC are around some of our big behavioral health programs with our inpatient program with integral care, and then our specialty care and post-acute care programs continue to have good numbers, but a little bit lower utilization as a result of COVID, similar to central health. And with that, I can answer any questions on either.
Questions, members? Thank you. That was an excellent presentation. And I do understand that continuing audit that you were talking about. Members, if there are no questions at this point, then we will move on to the next item on the agenda. There's no motion necessary. Seeing none, we will keep moving. Agenda item number 3, receive and discuss an update on community engagement and the results of the community survey regarding the proposed fiscal year 2022 strategic priorities and proposed budget. Yvonne Davila and Matt Richardson will be presenting. I will turn it over.
Thank you, Madam Chair. Yes, Ivan Davila here, and I'm the Director of Communications and Community Engagement, and I am joined by my colleague, Matt Richardson, who is a Senior Data Strategy Analyst, and he will share a brief summary of the survey findings as part of this presentation. What we're going to be sharing this evening is a high-level summary of the detailed 40-page preliminary engagement report that was included in your packet for this evening's meeting. We are calling this report a preliminary report, as the final fiscal year 2022 budget engagement report will be shared with you all prior to your vote on the budget, September 9th. The final report will have a summary of comments we are receiving online, and also our community conversation that we're having on Thursday, and as well as comments that we're receiving on during the public hearing on September 2nd. So this is the preliminary report. Brianna, next slide, please. Our goals for our fiscal year 2022 budget community engagement process are on the screen. We felt we couldn't do number 2 without number 1. So number 1 was educate members and that is MAP members, and the public as a whole about Central Health functions, how it pays for medical services, and its budget priorities and strategies for fiscal year 2022. And number 2, gather community input on the proposed budget priorities and strategies. Next slide, please. Next, we're going to go over our engagement, outreach, and communications tactics that we have been using. Next slide, please. This is a list of community engagement tactics. So as you all know, we hold community conversations, and since COVID, we have been holding those via Facebook Live. And new last year, we began holding community conversations in English and in Spanish. So last June 17th at 11:30, we held a community conversation in English and one at 1 o'clock in Spanish, and that was on Central Health's 2022 priorities. And as of earlier today, the English community conversation had about 470 views, and the Spanish community conversation had 111 views. As I mentioned earlier, there is a community conversation scheduled to take place this Thursday, August 26th at 11:30 in English and 1 p.m. in Spanish. Again, this will be taking place via Facebook Live. The preliminary report in your packet has a long list of community groups with whom we have been engaging. And so I'm not going to go over the list of community groups that we've been engaging. So my colleague Yesenia and I have been attending some community meetings to share the presentation on the strategies and how people can get involved to provide feedback. Because we highly value input from our patient population, our MAP members and MAP basic members, we consistently engage with them by employing feedback gathering tools that meet them where they are. So in this instance, due to COVID, we have been conducting telephone interviews. And so we've been conducting the survey, administering the survey by doing telephone interviews. So members of our outreach team and members of our engagement team have been directly picking up the phone and calling MAP members to conduct the survey. The survey was collaboratively designed with help from our community outreach staff, which is made up of community health workers as well, and our data analytics team. The community engagement outreach team worked with analytics and reporting to develop, test, and deploy online and telephone surveys. While largely similar, the telephone survey was adapted and reduced in length. The online survey, we used a recently launched engagement platform, which allows to engage with active members of our community, both online and by text. The platform offers a variety of engagement tools like discussion forums, polls, idea boards, and surveys. And to gather feedback from engaged individuals, we use the online survey tool of this platform. We'll discuss our analysis of the responses from both the telephone interviews and online surveys throughout this presentation. So this is the engagement tactics. The next screen, Brenna has a list of the communications and outreach tactics that we've been using. So in terms of the newsletter and email invitations, we send bilingual Spanish and English email invitations about each community conversation to a list of more than 6,000 contacts. And we've also been sending bilingual weekly emails to our list of more than 600 contacts, asking them to participate in our budget engagement process by completing the online survey. Of course, we've included both community conversations and the budget survey in our newsletters as well. You all know we are very active on social media, so we have been also promoting this on social media, and our outreach team has been sharing posts about how to get involved in the budget process or budget development process to about 122 Facebook groups representing some of the community groups we engage with within our priority zip codes. And we also had our vendor, Belmont, advertising vendor, implement a highly targeted paid bilingual social media campaign targeting people living within our priority zip codes. And of course, as I mentioned earlier, direct phone calls to our MAP and MAP Basic members. Next, we're going to actually get into some of the details of the survey. Next slide, Brianna, and the next slide. This is a general overview and breakdown of the participants, the people who actually participated in our survey. So you can see on the screen, about 60% of them were non-MAP Basic members, and 40% were MAP Basic members. And then you'll see the racial and ethnic breakdown on the right-hand side. So in general, it is difficult to get a perfectly representative sample of a larger population. For the purpose of this survey, the sample is reasonably diverse and representative of the overall MAP Basic population. The sample of 205 individuals captured a diversity of community roles, ages, races, ethnicities, gender identities, and primary language, and is broadly representative of the Central Health MAP Basic member population. In terms of zip codes, the next slide, please. This map shows the zip codes where the survey respondents reside. While we targeted Central Health priority zip codes in our digital paid media efforts, in our MAP member outreach, we used a list that would help us reach a representative sample of membership based on race and ethnicity. So you can see how broad our coverage was. The darker the area, the higher the representation in the survey responses. So survey respondents represent almost each area of the county. And so next, I'm going to turn it over to my colleague Matt, who will give us a summary of the survey results as well as methodology. Matt.
Thank you, Yvonne. As he said, my name is Matt Richardson, and I'm a senior data strategy analyst in the analytics and reporting team here at Central Health. We've been supporting this work through the deployment of these online and telephone surveys to help ensure that you have the most useful data possible to support your decision making. I also wanted to acknowledge Jesse Patton Levine on our team, who provided a great deal of technical and data assistance, particularly with the phone survey. Yvonne reviewed the demographics for you, whereas I'll be speaking to the methodology and results. May I have the next? So as Yvonne mentioned earlier, we conducted 2 parallel surveys, an online survey through our new engagement platform and a telephone survey. Both were conducted in English and Spanish The online platform allowed anyone to participate, including MAP or MAP Basic members, community health champions, engaged stakeholders, partners, employees, and the general public. Staff conducted the online survey using Central Health's new Bang the Table engagement platform. It's great, and you can find it at participate.centralhealth.net. This online survey site included infographics, videos, and considerable text, and took around 20 minutes to complete during pilot testing. The telephone surveys were direct phone calls only to MAP and MAP Basic members who were part of a randomly selected pool of 691 active or recent members to get a sample that was representative of our member population in terms of race and ethnicity. These were long surveys. They were taking about 20 to 30 minutes each. You can see that the telephone survey had fewer questions. Some questions were omitted in order to keep the telephone survey time reasonable for the respondents, as few people want to participate in a phone survey longer than a half an hour. Of course, some of these phone surveys lasted much longer, as the participants had a great deal of information that they wanted to share with us about their experiences and their priorities, and several members expressed appreciation for the outreach and the opportunity to have their voices heard. And we appreciate the time that all the respondents dedicated to these surveys. We captured structured and optional open-ended responses, and the number and depth of those open-ended responses was considerable. And all of those responses were carefully reviewed, analyzed, and considered in our report. So what did we find? Let's take a look at the next slide. We found that we have a good story to tell based on these results. As Yvonne mentioned, the sample is largely representative of the people that we're trying to serve. First, strong majorities of respondents supported the proposed budget strategies, and we'll look at those in the next slide. But further, when we look at those results by community role, we see that the MAP and MAP Basic members were even more strongly supportive of these strategies. And also, we didn't just ask about the budget priorities. We drilled down deeper to understand what members' clinical experience was like with us when viewed through the lens of the proposed priorities. So for example, when asking about transitions of care strategies, we also asked questions like how often folks felt that they or someone they cared about had gotten lost in the shuffle between providers, or whether their doctor and care team understood and respected them, or if they had a voice in their care. And what we found was a little surprising. MAP and MAP Basic members largely reported that they were more satisfied than all the other respondents on clinical experience questions, even those with private insurance. However, we also heard that wait times, the referral process, and patient communication concerns are opportunities for continued improvement. So let's look at those specific strategies in the next slide. So I want to point out, with our apologies, that we only have time tonight to provide a high-level overview. However, our preliminary report is available to you in your board packet starting on page 242. And in there, you will find detailed analyses for each strategy. I encourage you to take a peek, as there's a great deal of direct feedback that gives insight into the community members' responses to our proposed strategies. During the surveys, information about our proposed plans was provided, usually followed by personal experience questions, and then each section asked the respondents to indicate how much they agreed or didn't with the proposed strategy. And if the participants strongly or somewhat disagreed, they were given an additional opportunity to tell us why. The strategies with the strongest support were healthcare for the homeless and substance use disorder treatment, both at 90.6% support, as you can see here. A trend that we saw throughout the MAP and MAP Basic members, that they were even more strongly in support of the strategies. So that is, they selected strongly agree more often. For example, the facility expansion strategy about these 3 new clinics, it showed that 54% of your non-members strongly agreed, whereas 71% of members strongly agreed. And this was common. We saw this not universally, but in most cases. I'd also like to note that the equity culture and long-term sustainability questions were not included in the telephone survey of our MAP and MAP Basic members. That was again because of time, and they had interactive features that weren't easy to duplicate over the telephone. And so those obviously have a smaller denominator of respondents, and those folks were largely not members. And as we know, the members more strongly supported the strategies. So aside from providing this information to you, the Board of Managers, what are we going to do with this? The knowledge gained from these surveys will be shared back internally with the service delivery operations staff, as well as the consultant for the strategic planning process. Also, as Yvonne mentioned, community input and conversations will continue, informed by the respondents' input preferences indicated in the survey results that they gave us. And lastly, the lessons learned from doing this whole budget survey will be captured and documented for next year. There's a great deal more information in the preliminary report, and I wish we had time to get into the nitty-gritty, nerdy details that I love tonight. but I appreciate the opportunity to share this work with you and to applaud all the hard work by the staff to get this done. Thank you very much for your time. I believe this concludes our formal remarks, but Yvonne and I would both be happy to answer any questions you may have.
Thank you very much.
Let me go ahead and underscore, I'm sorry, Madam Chair, our budget
Yes,
engagement process will continue until September 2nd, and members of the public can provide feedback or ask questions online by visiting participate.centralhealth.net/2022 budget or participa.centralhealth.net/presupuesto 2022.
Thank you so much. Thank you, Yvonne and Matt, and to all those who participated. Excellent work. And yes, I also do wish we could get into the nerdy details, but we have the backup, we had the preliminary report, and I know you will be providing more. So thank you again for this excellent work. Members, any questions at this point? Manager Valadez. You're on mute, Manager Valadez.
Thank you, Yvonne and Matt and your whole team, and to those that did the questioning. But what I briefly saw is that we didn't have, for all intents and purposes, any responses by Spanish speakers online. It was so few, I think just a couple of people. Most of those are those that don't speak English, and it's not necessarily Spanish, it could be another language. Those that do not speak English don't use the computer, which is exactly what we know and what we've been saying. So if there's a way to incorporate into the telephone conversations question for them to understand, because they basically do understand what equity means and those kinds of questions. I also noticed that I would think that the biggest problem is going to be what we have known all along, and that's the wait times. The wait times for specialty care. And I just want to tell you, that did show.
What is the exact question? It's about what was your question?
If there was a way for them to show or include questions that you all did not expand on or ask in the telephone conversation,
thank you.
Did in online, and those other than English speakers don't get an opportunity to respond.
Thank you. Thank you very much. Members, anything else at this time?
I hope you're going to do it. That's all I'm asking, Matt and Yvonne.
Yes, Manager Valadez, the only reason we omitted several questions was because the telephone interview they were taking more than 30 minutes. That was the only reason, right? And so we were being very specific to get meaningful feedback from the MAP member perspective in terms of their patient experience.
Thank you.
I would add that on the fiscal sustainability, it included a video that we asked them to watch, and we couldn't play that video during the phone.
That's right.
Right.
So there's some kind of practical things that played into that.
Thank you, Matt. And Manager Valadez, to get somebody to do 30 minutes itself is a miracle. So any other questions at this point? If not, we will move on. Not seeing any, so we will move on to agenda. I'm going to call up actually items 4, 5, and 6 together. Agenda item number 4, receive and discuss a presentation on the proposed Central Health fiscal year 2022 budget and tax rate. Agenda item number 5, discuss and take appropriate action on Central Health's proposed property tax rate for fiscal year 2022. And members, as a reminder, this item is the preliminary action we must take in connection with the tax rate for fiscal year 2022. Tonight, we will vote on the proposal to increase the tax rate to 11.1814 cents per $100 of taxable property value for the 2021 tax year, which will support the Central Health FY 2022 budget. The final vote on adoption of the tax rate is tentatively scheduled for September 9th after we have had a community conversation on the budget and the statutorily required public hearing. The date, time, and location for the required public hearing on the tax rate increase proposal will be formally announced in the next agenda item, which will allow staff to publish the required public notice in the newspaper and our website. So agenda item number 6 is set the date, time, and location for the public hearing at which the Central Health Board of Managers will present and receive comments from the public on the proposed fiscal year 2022 tax rate. And so I am going to let staff take up these related items of agenda items number 4, 5, and 6, and I have read all of them.
Thank you, Chair Greenberg. I'll lead off and then I'll hand it over to others. Tonight, we wanted to present some information to you, and it's in a slightly different format, and it's been repackaged because we wanted you to see what we were going to be presenting to the Travis County Commissioners Court in subsequent hearings. Tonight, as Chair Greenberg pointed out, is about the tax rate. It's about approval of the tax rate and then setting the date, time, and place for those hearings as is necessary for the healthcare district and a responsibility of the Board of Managers. You notice that the theme here, empowering communities of care, we wanted to add some context and start building a narrative around the budget and what is it that we're doing. And so you'll see this theme running throughout, and it guides a lot of our presentations that we'll have with you tonight, as well as with the Travis County Commissioners Court. And I will briefly review slides 1 through 16. You will notice a lot of this content in here is content that you've seen before. We're not going to belabor the points, and we're going to try to focus on what's new and then point out relevant or maybe salient points for this evening's consideration, especially as it relates to the tax rate adoption. But we, as presenters, we will move through these slides that maybe they look different, but it's for all intents and purposes, it's the same content, perhaps as what you've seen before. Next slide, please. So as I mentioned earlier, the request is to approve a proposed tax rate of 11.1814 cents per $100 of taxable property value. And this is 6% above the maintenance operations no new revenue tax rate, formerly known as the effective tax rate. And this will support our fiscal year 2022 budget of $506 million. And you can see the breakdown. And second, I'm sorry, we'll ask you to set the date, time, and location for the requisite public hearing. As you can see, the breakdown in the budget, healthcare delivery is at $491 million, administration 13.2, and tax collections at 2.1. Doing some quick math for you, you'll see that 97% for healthcare delivery. In the past, that has consistently been 96%, meaning 96 cents of the dollars that we take in are dedicated to healthcare delivery. And this year, it's 97%, so a slight change. Next slide, please. So empowering communities with care. And if before we get to the budget and the strategic objectives, it's understanding that we need to help people access healthcare and lead the healthiest life possible, or healthier lives. How do we do this? It's going to the margins, looking at often overlooked communities, and then collaborating with patients, providers, advocates, peer support, and just a whole wealth of individuals to address very significant issues and functions of the healthcare district, such as specialty care access, healthcare for the homeless, behavioral health, substance use disorder, clinic and patient education, which we saw results from tonight indicating concerns around clinic and patient education, and of course, transitions of care. Next slide, please. Well, these are proposed budget highlights. You've seen this before. It just groups it by categories as opposed maybe to orienting it towards the strategic objectives. Next slide, please. Then we get to the theme, empowering communities of care. And here we lead with connecting communities in terms of how we form what we do, how we develop what we do, and that includes 3 sections related to the medical access program, the community, and then of course elected officials. Next slide, please. So first is connecting with MAP members. This lists some of the, and again, this is information you've seen before, but it lists some of the key statistics about connecting with MAP members in terms of vaccine registration, Affordable Care Act enrollment assistance, direct mail, on COVID-19 prevention, testing, vaccines, phone calls, because there's a divide, Manager Valdez, as you pointed out, whether that's by technology or by language, having the ability to access people in high priority or high risk zip codes directly is and it will remain a priority for us. And of course, we have virtual town halls in the pandemic environment. And then we've also begun with our partners, Latino Healthcare Forum and Community Coalition for Health, and small business outreach as another channel to connect with the MAP members out in the community. Next slide, please. And again, keeping with the theme, empowering communities with care, we look at connecting with the community. And so this goes outside of the MAP patients, but still is valuable partners in those with whom we work. Community engagement was significantly increased over the past year. And then looking there are some statistics for digital media and traditional media, which we have, continued to build upon our successes and also our refinements in terms of how we use different media channels and modalities to connect with individual, but also to make impressions that, as you can see, the advertising equivalency value of $38 million is very significant in terms of how we connect. But again, not to overshadow what we do one-on-one, person-to-person, especially with our community healthcare workers and others that do direct outreach to individuals outside of media channels. Next slide, please. And then lastly, on empowering communities with care and sticking with the overarching theme is connecting with community leaders. These to be elected officials, predominantly Travis County Commissioners Court, but also City of Austin and other cities, throughout Travis County. You will see just two things here that I'll highlight. One is the budget book, which is now available online. Web links have been sent out. This is part of our transparency efforts, but it's also one of the reasons why we continue to be recognized by the Government Finance Officers Association. And then our spotlight reports. This was new for us this year, targeted predominantly at other elected officials, talking about how we function as a healthcare district, what our decision-making processes are, so that they can see some of the inner workings of Central Health. Next slide, please. So again, before we get to any budget numbers and strategic objectives and the things that we tend to create as foundational documents on which we base our work, we want to look at our culture. Who is it? In a very affirming way, who are we and what do we aspire to be? And one, building a culture of equity. And you'll hear some updates later tonight about our equity and inclusion task force, but you've been receiving updates on our hub disparity study, which is underway, and as well as our recruitment and pathways and training for our organization. We've got an expanded compliance program. Let's thank to McKinsey for bringing us to where we need to be and continues to do work there. And then focusing on change management and cross-organizational alignment. I want to focus on this third bullet for just have a quick aside on this one. We're growing as a healthcare district. We're not all that old. We're still young. And so there's a lot of things that we're going through. You've seen it, part driven by changes in federal funding, but in part driven by changes in Travis County, the individuals that we're privileged to serve, changes in healthcare delivery that we've learned in this pandemic, and then even outside of the pandemic environments. And so really spending a lot of time on how we manage change at the executive leadership level, but also cross-organizational alignment with our partners, even outside of Central Health, meaning Sendero and community care. Moving on, also focusing on organizational strategies for critical areas. What is it that we really need to be good at in facilities and technology and administration, et cetera? There's other lists. This list could go on and on of other areas related to support operations, but we want to be calling those out in the budget resolution, which you'll see later in the budget process, so that there is acknowledgement that this work needs to be done, but also it's a way for organizations to give themselves permission to say, yes, we have to be great at the basic blocking and tackling if we're going to be a great organization to support the culture that we want to support. And then, of course, I mentioned the Government Finance Officers Association Award, which is something that this board has supported. We appreciate that, but also Travis County Commissioners Court, as it reflects our level of transparency and our sophistication in our budgeting processes, but also our forecasting and other fiscal and financial management issue areas. Next slide, please. So again, you've seen the slide. It's the strategic priorities. The prior slide that you saw a few slides back was organized in categorical, maybe topic areas. This is organized around the strategic objectives that the board has set back in 2018 and will carry us through 2024. Next slide, please. You've seen the budget survey results as an affirmation that the strategic objectives that you all have set and that we've talked about as part of our proposed budget process with the board, you all have given us, I would say, permission to continue to move forward as we presented it. As you can see, those received very strong and favorable results that, yes, we are headed in the right direction. Next slide, please. So I'll quickly go through these next 3 slides, but the rest provides a visual, and this is important. I think not only we're making presentations to the board and the court, but also publicly about where we are with our key objectives. So obviously the first objective based on people in place, highlighting the Del Valley, Hornsby Bend, and Colony Park. As mentioned earlier, the Del Valley and Hornsby Bend site plans have been submitted or are awaiting approval for both Del Valley and Hornsby Bend, and then and then documents have been posted in their live procurement process for site and construction work. So those are actively moving along the timeline. I know that was a question that came up earlier in the evening. And then if you'll go to the next slide, please. Although we are not as far along, and we'll have an update later. We have a separate agenda item for Colony Park. We're not as far along on Colony Park as we would like to be, or relative to Hornsby Bend and Del Valley, but nonetheless, we have established a health resource center there and continue to move forward on the larger health and wellness center construction. Next slide, please. The second objective, again, you've seen this slide before. It highlights the new spending under our patient-focused and coordinated healthcare spending. And again, I want to emphasize, this is new spending. This is in addition to what we were already doing in our current fiscal year. Next slide, please. This goes into a little more detail on the downtown property, and this is one of the questions that Manager Valdez, you had raised, which is, where are we with these things? And so what this slide shows is some of the dollar amounts that we've received in lease payments, but also to draw your attention to that 4th bullet point. Central Health will continue to evaluate development options in other parts of the property. Again, this is something we need to bring back to the board later this year. To show this is what we think makes the most sense in terms of how we proceed. Next slide, please. And again, you've seen this before. This is the illustration of our systems based through equity lens work in terms of how we fill the gaps in the healthcare system. So again, a lot of this material you've seen. I know I went through it quickly, but we wanted you to get a flavor of what it is that we're going to be presenting to the Travis County Commissioners Court. There are voluminous appendices that we've also attached to these presentations, both this one here tonight, as well as future presentations to the Travis County Commissioners Court. So they have access to all the information, prior slides. And that way, if there's any questions, we can reference those slides if necessary to answer those questions. Next slide, please. And this is my cue to turn it over to the finance team. Thank you.
Thank you.
Thank you, Mike. Good evening, Lisa Owens, Deputy CFO. So I'm going to go through our final proposed budget. This is, I believe, our 4th presentation on some numbers. We presented a preliminary proposed budget in June. We did a deep dive at the end of June on our healthcare delivery program, which is the majority of our spending. Then we came back after break and brought you our final proposed budget on August 11th. And I just wanted to, I'm going to move fairly quickly through this because we have not made any changes to the numbers since that presentation. So the final proposed budget numbers that you saw on August 11th are in here. And we went over the variances at that time, and I'm going to hit some of the highlights. So we can go to the next slide. We talked at length on the 11th about the long-term approach to our planning. We start this in May when we talk about our long-term approach, and we pulled this together to show different variables in the proposed tax rate, showing that we are targeting that 120 to 150 days of cash on hand in the long term. And so we prepared a slide to summarize that and some of the uses of cash that we know are happening in the future. Next slide. So the proposed tax rate, again, tonight we're asking you to approve the beginning of the tax rate setting process. We will come back in September to actually ask for action on the final approval of the tax rate. So the proposed tax rate that we would like to move forward with tonight is 11.1814 cents per $100 of valuation. And as you've seen on this slide before, we do estimate that to be an increase to the average homestead pair at about $40. And we also increased our homestead exemption for over 65 and disabilities up to 100,000. It was at 85,500 prior to this year. And we estimate that will provide significant relief on that tax bill. So that is again at 6% over the no new revenue rate, which is the former effective rate, plus a debt service rate. That includes the additional debt that we authorized today. Next slide. Again, I'm going to just skip over this, but we do like to show that we do have the lowest property tax rate and percentage of bill compared to our peers in the other healthcare districts. And if we can go to the next slide. So our sources and uses, again, the proposed property tax revenue and the sources is about approximately $260 million for FY22. This is an increase of $26 million. In addition, we anticipate that lease revenue to continue from the properties that Mike discussed on the earlier slide on the downtown campus. And then that's a total of $280 million in sources of funds. And we've talked at length about the contingency reserve, which is one of our financial policies on our website that we've had for a long time, but we use the contingency reserve to plan for longer term initiatives and one-time events. And so the carry forward that we anticipate from our year-end estimate is approximately $226 million. And that's a total of $506 million in sources of funds. As we've talked about, we prepare a structurally balanced budget. So we also have uses of funds of $506 million. And we always maintain an emergency reserve, which is approximately 15% of our some of our uses. And so if we can go on to the uses of funds, again, I'm just going to hit some highlights. We went through these in great detail earlier this month. We are planning additional funds in the healthcare services. So this slide really shows, and I know there were some questions from one of our managers about the $7.3 million in additional funding, MAP eligibility, MAP expansion. A lot of that was discussed at our June 30th meeting. Those are found in these areas. If it's an initiative that's delivered in a primary care setting through one of our FQ partners, that would be in the primary care line. And if it's a specialty care deliverable, it would be in specialty care. So the bulk of those expenditures that we're investing in to add dollars to different program areas that we've been talking about throughout this process are in this area. Our total proposed budget in healthcare services for FY22 is $101.6 million. Next slide. In the healthcare operations and support, this includes not only our ACA premium assistance programs that we have, also our healthcare facilities and campus redevelopment. We are increasing the funds to the ACA premium assistance program that will support enrolling additional high-risk members. And then in the last segment of this, throughout the salaries and benefits, all the way down to the bottom line there, that was all presented in our business cases. Those are the departments, which we'll get to in a later slide, that support our healthcare delivery. Additional funds there were supported through our robust business case process. So a total this year of $56.9 million in healthcare operations. Next slide. This is our reserves and appropriations and transfers, as well as debt service. So those also represent, again, that structurally balanced budget. Additional cash reserves going into the capital reserves for projects that won't be funded through debt, that would be funded through cash. And then the additional debt service payment that is going to be funded through that debt service rate that we talked about earlier. We do estimate contingency reserve appropriation in healthcare delivery of just under $300 million. Our total healthcare delivery budget is $491 million for FY 2022. And then on the next slide, we have our administration and tax collection program. We do also have business cases that support additional FTEs, staff, as well as programmatic dollars that may be needed to achieve that operational excellence that Mike walked through earlier. And again, we presented the business cases in detail on the 11th, and I believe they're in the appendix. So our total administration program is at $13.2 million, just over $2 million in tax collection expenses. And that puts our total uses, healthcare delivery and administration, at $506.8 million. These next two slides, we can go to the next slide. I'm not going to go through in detail. We shared them with you at our last presentation at the request of one of our managers for more information about the business cases, as well as new FTEs, salaries, and additional information in the different functional areas in our healthcare delivery program. And then on the next slide, you'll see the different the changes year over year proposed in staff and in salaries in the administration program. On the next slide, I believe we have the capital reserves. We do anticipate an additional transfer to the capital reserves of $12.5 million in FY 2022. And again, those are estimates to support ongoing operations, but also additional efforts that might be needed outside of debt financing. On the next slide, I believe we can skip right over this because we've done all these meetings. So here we are. So I'll just close out with what we started with, which is tonight we are here to ask the managers to establish that proposed tax rate so that we can begin the public hearing, and also to announce the date and time of that public hearing. We will be back in front of you on September 2nd with the public hearing. As well, then on September 9th, we will be asking for the final vote on the budget and the tax rate that we will be bringing forward for final vote. And then we will go to the Commissioner's Court on September 21st. So appreciate all your support throughout this process. And I think with that, I will turn it back to you, Chair Greenberg, for the next steps on
Yes, thank you.
questions or the tax rate.
Yes, thank you very much. Very comprehensive. Thank you to you and to Mike Giesel and to all those who helped with these presentations. Members, are there any questions at this time? Manager Valadez. You're on mute, Manager Valadez.
I have one, and that's clarification on that increase on the contingency reserve from, I think it was 12 something or however many was to 298 million.
And this is not a change from June, correct, Lisa? We saw this in June.
I need a little clarification. Are you talking about the capital reserves?
If you can go back, it's a small number in the contingency reserve, and then for 21 and for 22, it's at, I think, 298 million. And I think you have explained it to me, but for some reason or other, it's flown out of my brain. Just real quickly.
Sure. So we structurally balance the budget. So we anticipate having a contingency reserve carry forward to start the year of $226 million. And then we appropriate the difference in the healthcare program. I believe you're referencing the appropriation of $298 million in FY22. Yes. And that's available for healthcare resources. And if you go back to the long-term look, the long-term outlook and the long-term needs of the organization, that those funds are carried forward for current year uses and future uses.
Thank you, Lisa. I appreciate that.
Yeah. So Lisa, we budget, then we appropriate, then we encumber, correct?
Right.
Okay, thank you. Any other questions? If there are none, then I will accept a motion. Manager Bell, do you have a motion?
I move that the board approve a proposed total property tax rate of 11.1814 cents per $100 of taxable property value for the 2021 tax year, which will support Central Health's fiscal year 2022 budget.
We have a motion. Is there a second? Manager Valdez? Okay. A motion by Manager Bell, second by Manager Valdez. I am going to this motion, we will need a roll call vote. So I'm going to ask Ms. Brianna Yanes to assist us in taking a roll call vote. And I believe Manager Motwani has joined us by telephone, so you cannot see him, but he will be available for the roll call vote. So for the roll call vote, Ms. Yanes will call the name of each board member in attendance in alphabetical order. Each board member must indicate whether they are voting yay or nay or abstaining from a vote on the proposed tax rate increase. Ms. Yanes will confirm your vote before moving on to the next member to ensure we have an accurate vote tally. I will let her commence. Thank you.
With that, I will call the roll. So Chairperson Sherry Greenberg.
Yay.
Chairperson Sherry Greenberg votes yay. Vice Chairperson Dr. Charles Bell.
Yay.
Vice Chairperson Dr. Charles Bell votes yay. Treasurer Julie Zuniga.
Yay.
Treasurer Julie Zuniga votes yay. Secretary Cynthia Valadez.
Yay.
Secretary Cynthia Valadez votes yay. Manager Cynthia Brinson.
Manager Brinson, you need to respond.
Yes, yay.
Yay. Okay.
Manager Cynthia Brinson votes yay. Manager Shannon Jones.
Yay.
Manager Shannon Jones votes yay. Manager Amit Motwani.
Yay.
Manager Amit Motwani votes yay. Manager Mara Musaitis.
Yay.
Manager Mara Musaitis votes yay. And Manager Dr. Guadalupe Zamora.
Yay.
Manager Dr. Guadalupe Zamora votes yay.
That completes the roll call vote, correct, Ms. Yanes?
Correct.
Thank you. And we have a unanimous vote, is that correct? Yes?
Yes.
Thank you, members. The motion passes unanimously. All right, we will now move on to agenda item number 6, which is set the date, time, and location for the public hearing at which the Central Health Board of Managers will present and receive comments from the public on the proposed fiscal year 2022 tax rate. Manager Bell, yes.
I move that the public hearing on the proposed tax rate increase, the proposed tax rate increase be held on Thursday, September 2nd, 2021 at 5 p.m. at the Central Health's Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, a notice for which will be posted on the Central Health website and published in a general circulation newspaper in Travis County.
We have a motion by Manager Bell. Is there a second? Manager Valadez?
Second.
We have a motion and a second. Members, we will now proceed to vote. All those in favor?
Aye.
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 Opposed? Any opposed, same sign. Any abstaining? Thank you. Members, the motion passes unanimously. Members, before we move on from this item, I would like to emphasize to the members of the public watching tonight that even though a quorum of the board will be meeting in person due to the expiration of the governor's waiver of the Open Meetings Act's requirements, the public can still participate virtually in the tax rate public hearing, as several of our board members also will be participating virtually. Due to the surge in COVID-19 cases locally, we strongly encourage all members of the public to watch the meeting on the virtual link that will be provided in the notice and to submit any comments through that virtual means method rather than attending in person. Members, we will now move to item number 10, receive a briefing on and discuss fiscal year 2021 strategic objectives per board adopted budget resolution or board directive, and receive updates on specific items, including A, current workforce demographics and levels, including new hires and turnover. And B, workforce culture update on Central Health's diversity and inclusion initiatives. Jana Allen will be presenting on sub-item B. There's a report, members, that's in your backup packet from Susan Willers regarding workforce demographics, so please refer to that report. I will hand it over now to Jana Allen.
Good afternoon, managers. I believe Susan Willers was wanting to make a comment, Madam Chair,
Okay.
before I present.
Okay, Susan, do you have a comment? Susan, are you with us?
Okay.
Susan, I see you. Are you on mute?
It's fine. I just wanted to, she had discussed with me prior that she had an announcement that she was wanting to, or a comment that she was wanting to make. But knowing what that is, I will give that in her absence. It's really great to see y'all.
I will say she is present, but she seems to be having problems with her audio. So if you could, Jana, that would be much appreciated. Thank you.
Yes. So good afternoon, managers. I'm Jana Allen Hines, and it's a pleasure to be here with you all tonight to just give an update and an overview as far as Central Health's diversity, equity, and inclusion journey thus far. But before that, just to give an update on this position, this role, I was promoted from our community engagement team into this role, serving under Susan Willers in December of 2020. And since then, throughout the pandemic, as so many folks have made changes, it's really been meaningful to get to work remotely and virtually with everyone here. But I've since permanently relocated to Durham, North Carolina. And so I'm in the process of helping Susan and Mike Giesland and our Equity and Inclusion Task Force team work through how we transition this work and how we keep the momentum that the folks in the Equity and Inclusion Task Force and so many members of our staff have given their energy to, and a lot of momentum that's just been gained over the past year. So that's a personal and professional update, is why you see the interim at the beginning of my title there on the slide. And with that, I also want to acknowledge that you've received updates in the past as far as diversity, equity, and inclusion, primarily from Mike and from Susan. And so this is really carrying that work forward as far as what's come about since December 2020. And so I also want to just thank Mike, Susan, Sherelle, Yvonne, the members of the Equity and Inclusion Task Force team for their efforts in really establishing this work prior to this role existing. So next slide, please.
So Jana Allen Hines, I want to thank you for all of your work. It has been so valuable. You are deeply appreciated. We are very eternally grateful. Thank you.
Thank you so much, Madam Chair. Okay, next slide. Okay, thank you so much. So understanding Central Health's diversity, equity, and inclusion journey. As I mentioned before, there have been a lot of efforts that predate me and coming into this work, and really my role has been to formalize and create a structure and a sustainable foundation for how we work on our internal culture. And that's one thing I want to highlight from the onset of our conversation, is that when we talk about diversity, equity, and inclusion, we're focused on Central Health as an organization, though there is some work with our thought partners around the larger conversations about equity, but we're focused on our culture, our conversations, who we are internally as an employer primarily. Next slide. So the Equity and Inclusion Task Force, as I mentioned previously, this was created in 2019. I had the pleasure of serving on it in my previous role when I was in community engagement, but this was created in 2019 under the leadership of our CEO, Mike Giesland. And really in those early stages, the purpose of the group was convening a group of staff who were going to come together, and we were having conversations about the culture and how we were going to have conversations around issues of diversity. From there, because the Central Health staff are just so amazing and innovative and know how to take initiative, from there we created a structure and ideas for how this work is going to move forward. And so the Equity and Inclusion Task Force created a purpose statement, a vision statement, and value statements, along with goals and objectives for the organization. And I do want to give one caveat that this work of how to be a more equitable and more inclusive organization is always ongoing. There is no real finish line. We will always do better to better understand the people around us. But for now, this is what we have in terms of a purpose statement and a vision statement, and it will continue to grow the more we learn. So I'll share that purpose statement with you, that we believe all differences, visible and invisible, help us problem solve issues at large. We embrace all cultures and all voices within our organizations and communities. We encourage and acknowledge diversity of ideas, perspectives, and backgrounds are critical for enterprise success and patient advocating. We believe in fairness and recognizing all the differences that enhance our community. Central Health stands up for those experiencing health inequities and strives for everyone to have a healthy life. Through honest dialogue with the community and collaborating with our partners, we create access to care for those who need it most. During the discussions around the purpose statement and the vision statement, it was really important to our members of the task force to stay centered on our mission, to stay centered on the folks who use Central Health Services, the folks using MAP, the folks who are trusting us with their care. And that came through all throughout the process. And so you'll continue to see that in our goals as well, that honoring our internal work as an organization, as well as externally how the public receives us and interacts with us. Next slide. And this was the vision statement. This was in collaboration with Central Health's larger vision statement for the county. Central Health Enterprise envisions a Travis County community with access to high quality healthcare through fostering a workforce that is equitable and reflective of our target population. And that's something that in my previous life and community engagement that we hear so often from folks, is that people who are using our services want to be able to connect with folks who speak their language, folks who look like them, folks with a similar lived experience who understand what it's like to use our services, to call the MAP hotline, to call a clinic, and so that we can better serve them and have that understanding of what everything they're bringing into their experience interacting with Central Health. And so that was really important to the group as we discussed our vision statement. Next slide. And so from there, once we were in the high thought process of vision and purpose, we really wanted to make this tangible of how will we hold ourselves accountable to some goals. And so 5 goals were created, and I'll just share them with you now. The first one, ensuring leadership, commitment, and accountability to the diversity, equity, and inclusion initiatives. Number 2, fostering a collaborative culture, supporting staff growth and development, creating a diverse and inclusive environment throughout the recruitment, retention, and promotion process. And 5, ensuring mission effectiveness through equity, diversity, and inclusion efforts. And so as we were having, we were having conversations about these goals and these objectives and what they were going to mean to the organization, the key thing was, how do we make these tangible? How do we make these tangible and practical for the organization? And so then once the task force created these objectives, they got into subcommittees, and those subcommittees worked on the tactics that would be needed in order to reach these goals and objectives. And that work took place over the course of a few months. And during those conversations, following those conversations rather, those tactics were then shared with our internal subject matter experts, taken to the executive teams that corresponded with the goal. So for example, on creating a diverse and inclusive environment throughout the recruitment, retention, and promotion process, we found that there were some tactics that the task force recommended that were already happening within the organization. It was a matter of communicating them and sharing them. For example, you regularly receive updates from Betsy and Susan as far as demographics. And so there's work being done on recruitment and retention, but how can the task force, how can the organization continue to grow in recruiting diverse candidate pools? How can we continue to grow in retaining staff from marginalized identities? And so those tactics, when they were given to the subject matter experts, we saw that there was a lot of work already happening, but just needed to be communicated. And there were a lot of areas to work together on some new initiatives. Next slide. So a key part of this foundation of our diversity, equity, and inclusion journey, if you remember, goal 1 was ensuring leadership, accountability, and commitment throughout the organization. And number 2, the second goal was fostering a collaborative culture. In my role, the first thing that was important to me in order to do those 2 things was having our executive teams and our manager teams go through a diversity and inclusion awareness training, followed by our 250 plus employees between Central Health and Sendero staff also going through this awareness training. Because in order to foster a collaborative culture or to be accountable to this work, we have to know what we're talking about. So with this awareness training, the goal was to create a shared common language. That was a tactic that the group from Goal 1 recommended, was just making sure that we have a common set of definitions for what we're talking about. So in this training, we defined what is diversity, what is equity, what is inclusion, and based off of DEI scholarship and understanding where this came from. So next slide, I'll show you an example of when we were talking about the goals of this training. So the first goal, create a common language and shared understanding of the significance of diversity, equity, and inclusion in the workplace, along with the history, to provide an overview of Central Health's DEI journey, and to understand how employees can apply DEI frameworks and resources within their role in the organization. And so next slide. When we were talking about creating that shared language and history, it was very important to talk about what this came out of. Diversity, equity, and inclusion is often talked about now in many workplaces. It's common, it's trendy, there's a very clear need for it. But at the same time, we have to ground ourselves in the history of why this work started. We have to ground ourselves in the history that workplaces were not always equitable or inclusive, and who was being left out, who was being marginalized, who didn't have access to that. And so that's where we go back and talk about the Civil Rights Act of 1964. That is the landmark labor law decision that started saying folks cannot be discriminated based on those protected classes of color, religion, race, sex, national origin, so on and so forth. And that is where we start this conversation, is looking at who's been historically excluded from the workplace. And so it was important to ground ourselves in that history so that we can then move forward with a shared language and shared understanding. Next slide. So we also talked about having tools for growing and understanding where we are in a journey. That's a phrase that we use often. My conversations with Mike, Susan, and publicly is that there is no finish line for us in learning to be more inclusive. This is ongoing work. But we do have a tool that I really appreciate called the Inclusive Leader Continuum. And it's understanding where we are in our journeys of being unaware, aware, active, or being an advocate. And this was a tool that we showed to the staff, and an assessment that was a free assessment that they could take to see where they were in their journey of understanding inclusivity, to see the things that they were mindful of. Even organizationally, this tool has been helpful for me in terms of understanding where we are in our journey, that we're in a very active stage in terms of moving initiatives forward, doing a lot of work to be more inclusive, to increase language access, to work to be in the same spaces with marginalized folks. And we're doing a lot of that work, but we still have a ways to go to get to that advocate stage where that's how we're known publicly, that's how we're known internally. But this continuum helps us see where we are on our journey, both personally and organizationally. Next slide. Another goal was, again, a part of that fostering a collaborative culture, but also being able to promote opportunities for development. One of the tactics that came out of that was the creation of employee resource groups. Next slide. And I'll give a little bit of background on what employee resource groups are and where we are in the process of finalizing them. So employee resource groups are employee-led, self-directed voluntary groups that offer opportunities to network, attract a diverse employee base, provide inclusion of ideas and solutions, and create opportunity for mentoring and career development. But they're also thought partners of the organization. And that's something that has been really important, the same way that the Equity and Inclusion Task Force has been a thought partner to Central Health on different initiatives that have come up. We've been able to hear from Monica on the systems prioritization work and give feedback and be thought partners in that work. Employee resource groups are another meaningful way to do that. So these employee resource groups tap into the extraordinary resources that are brought to mental health by its employees, and they can increase employee engagement, champion diversity and inclusion, and embed D&I into the enterprise strategic efforts and policies. And also, these employee resource groups are pivotal as showing a sense of belonging within an organization, especially for groups that have historically been marginalized or excluded. It provides a space of empathy and cultural warmth, as well as, again, shaping some of that thought partnership for the organization. Next slide. So here's where we are in the development of our employee resource groups. This was just a little bit of understanding the common purpose, the interest, is that folks will have, we've created a charter, and employees will be able to use that charter to state what their group's purpose is, or the interest, or the background, or identity that they represent, the background. And a committee has reviewed that charter. So a committee from our Equity and Inclusion Task Force, excuse me, they've reviewed the charter as well as the application process, and they're still providing feedback on that process, but they'll be able to, when they get started, have funds for activities, to have an educational event, to have something to promote throughout the enterprise. And so that budget has been secured for the upcoming fiscal year for employee resource groups. Next slide. So that is where, that's a very broad overview of where we are right now. And that's really phase one of this work. Again, phase one, the emphasis is having a shared language, having awareness of what diversity, equity, and inclusion is, and just being able to speak the same language. It's also just having that similar training, but we have to go deeper than that. So next steps, next slide. Phase two is a deeper health equity training so that we'd all be tied very closely to how equity and inclusion, diversity, equity, and inclusion impacts our mission, impacts the folks using Central Health Services as employees of this healthcare district. And so this equity training to take a deeper look focused on racial equity and how it's impacting folks' experiences with health, that we're still finalizing the RFP process for that equity training. In phase three, hopefully after a year of having these initiatives and efforts in place, would be, and this was recommended by goal group number 5, is having a professional assessment of those DEI efforts to see what's worked, what hasn't worked, and where we can continue to go forward in the organization. And so with that, that is my overview of what we've done so far. And I'll stop talking and we can stop sharing the screen if there's any questions.
Wow, that is just amazing, incredible work. And I know, Jana, that this has been, your heart and soul, as well as that of many, many employees with our Central Health organization. So thank you to you and to all of those employees who have contributed to this incredible effort. There, as you pointed out, has more to be done and more steps, but we will proceed. And thank you again for all that you have done, Jana. Members, are there any questions at this time? Manager Valadez.
Hold on, just one. If we have, because this also goes with it speaks to turnover, employee turnover, Jana and Susan. If there are employees that have had a problem, they've left Central Health or in the process of leaving Central Health because they didn't feel as if they had anyone that they could go to advocate for them or to understand them. I was wondering if there is a place for them to go, or has this come up? Because I know that there is at least 1 or 2 other cases right now. Unfortunately.
Thank you, Manager Valdez. Susan, is this something you want to address, or Jana?
Sure.
Can
you all hear me?
Yes, actually, whatever you did, we can hear you now.
Great. So thank you all. And I apologize for my audio issues earlier.
No worries.
So Manager Valadez, I think right now, what we did about a year ago is we went on a roadshow with a revised policy to our discrimination, harassment, and retaliation policy. And we outlined some new avenues that we put a focus group of employees together to tell us what we could do to provide a safe space for our staff to voice concerns. And we were in human resources, we were so surprised with some of the things that they told us to put in place that from an HR perspective, we would have never thought of. So we were very glad that we heard these employees telling us, number one, as an example, we should have dedicated emails like from Sendero to human resources specifically, community care to HR, and also Central Health to human resources. That's 1. 2, we allowed them, we promoted our compliance department as well. So we want to make sure that that's an avenue that they can take if they don't feel comfortable for whatever reason coming to human resources, that they can always reach out to our compliance officers throughout the enterprise. And there were several other things we put in place. We put 5 things in place to help them. And certainly even Jana was able to, establish great rapport immediately with our staff, that she has even been contacted, and then she routes them over to human resources. So we're in a much better place than we were a year ago.
Thank you so much. Managers, anything else on this item before we move to agenda item number 7? Manager Jones.
Yes, I just want to make a statement and we can move on. But first of all, Jana, we're going to miss you, and thank you so very much for your being part of the team and going forth and bringing us forth. So thanks again, and best of luck to you as well. I just want to say that, as we look towards achieving these goals, at some point or some markers along the way, it would be helpful for us to say, have a profile of our reflectiveness of the community that we can look at and talk about, and not just talk about what we want to get all of the time. Because my concern is that we do an excellent job of talking, an excellent job of preparing stuff. But the bottom line is, what do we result in? And so it would be helpful. And I know we do those demographic reports. I haven't seen one in a while, but it would be helpful maybe to look at that and see where we are now.
I hear you, Manager Jones. I think what you're asking for is, what are the outcomes and how do we decide what we're going to look for? Would that be correct, Manager Jones?
Absolutely, yes.
Okay, good point. And I think that this is something, Susan, that we would put back to you to have some discussions with staff on, okay? And then bring it back to us, what there would be suggestions. And I think, Mike, you wanted to weigh in on this.
Yes, and so we've provided quarterly workforce demographic reports that break the demographics down, disaggregates it by race and ethnicity and gender identity, and then it shows it also by where you are in the organization. So we're going to continue to do that. I know that in executive committee, we previewed some upcoming meetings where we'll also talk about our recruitment and retention pathways and what the results have been with those efforts. And that's something that has been, the results of which have been presented on, I think, one other time before, because they're relatively new initiatives. But I also want to emphasize, and members, if you'll indulge me just for 2 more points here quickly, that the work that Jana has outlined, we say work, but it's a way of being. When you think about culture, and you absolutely, you need to look at your workforce demographics on a regular basis to see how we are reflective or not of the communities that we're privileged to serve. But also, it's just having that culture where we know that this is something that we want to be continuously, and measuring culture is hard to measure. We have employee engagement surveys that we go out and ask opinions and perceptions of, but that in and of itself is something that just needs to be something that we be, and we talk about and I understand what you're saying, Manager Jones, how it seems like, there's a lot of discussions around this, and you're right. But I think that's something that we bring back to the board and not just talk about at the management level. We want the board to be aware of this as well, because this is an outward facing form in which we can have those declarations and reaffirmations and commitments to what it is that we ultimately want to be as we go on this journey, even if it's hard to mark off the mileage, so to speak, as we travel. So the last thing that I'd like to make is a point that I'd like to make is, Jana, thank you so much. You are an incredible leader. You're somebody that I could pick up the phone and ask your honest opinion about where we're headed, what to say, the moments that we're in as an organization or a culture or as a society. You weren't afraid to lead us through very difficult conversations outside of our comfort zones, but then back to a place where we were better off for the time spent. So thank you very much for your service, and look forward to our paths crossing again. Take care.
Thank you so much. Round of
Manager Green.
Yes, Susan, please.
Yes, I just want to remind the Board of Managers that the demographics for the 3rd quarter are in your packet.
Right.
Yes. So, yes, thank you.
Yes, they are in the packet. And Mike, thank you for sharing that. Managers, we will now move to agenda item number 7. Receive an update and take appropriate action on an interlocal agreement with the City of Austin for the purchase of property and preliminary design for Colony Park Clinic. Mike Giesland, Stephanie McDonald, and David Duncan will be presenting. I will turn over to them.
Yes, thank you, members. So currently with Colony Park, as I mentioned.
Members, if you're not speaking, please, everybody mute.
Sound check, can you hear me okay? Excellent, thank you. So members, as we mentioned earlier, Colony Park is one of our Eastern Travis County priority areas. Obviously, it's not where we want it to be in terms of advancing the project relative to Hornsby Bend or Del Valley, but where are we? We are still in the process of hopefully finalizing the land transaction with the city. We are endeavoring to buy acreage from the City of Austin. Right now, that is encapsulated in a legal document known as a purchase sale agreement that is being circulated between City of Austin and Central Health attorneys. Our goal is to turn something around as quickly as possible and get it over to the city, because we would like to have this on the September 2nd agenda to be able to do the land transaction. Without getting into any numbers, I think that would necessitate us going into closed session, but let me just say generally what the deal will look like. It will be a purchase of acreage with what I call either a long earnest period or maybe a pay-as-you-go. They're, for all intents and purposes, just conversational terms, but essentially we would buy the land from the city and then, with a modest down payment, based on appraised value, but then as improvements are made, for instance, application of the entitlements, the necessary zoning or rezonings or designations, the utility infrastructure, then we would encumber those costs. Now, our costs would be capped at what the appraised property value is. And then we obviously are talking between legal counsels about how to protect Central Health's interests should somebody default. And then we don't want to be left in a position where we haven't, as good stewards, maintained control of funds and then protected the interest that would enable us to continue to go forward in Colony Park should any one of the parties default in a way that's adversarial or not advantageous to Central Health. So that's where we are. I think the next step, again, is to get this to council and then commence work quickly on an interlocal agreement. David, correct me if I'm getting this out of sequence. That then spells out the terms of the various partnerships that are possible there on the property, including working with the City of Austin, Library Services, Austin Public Health, and others. So that's where we are. Thank you.
Appreciate the update. Okay. Unless there's anything else, we will move to item number 8. Receive and take appropriate action on revisions to the plan, fiduciary, and administrator designation and renaming of the committee responsible for the Central Health retirement and deferred compensation plans. Jeff Canoda will be presenting. Jeff?
Thank you, Chair Greenberg. There was information.
Apologies, Chair Greenberg. You moved on from item 7, and there was a motion at the end of item 7.
Okay, we will move back to item number 7, receive an update and take appropriate action on the interlocal agreement with the City of Austin for the purchase of property and preliminary design for the Colony Park Clinic. I call on Manager Bell.
I move that the board authorize the president and CEO to negotiate and enter into one or more agreements with the City of Austin for the purchase of property and preliminary design for Colony Park Clinic on terms similar to those presented or more favorable to the Central Health.
There's a motion. Is there a second? Manager Valadez? Second by Manager Valadez. Okay, any discussion? We'll go ahead and vote. All those in favor? Aye.
Aye.
Opposed, same sign. Any abstaining? Thank you, members. The motion passes. Now I will go back to, thank you, to item number 8, receive and take appropriate action on revisions to the plan, fiduciary and administrator designation and renaming of the committees committee responsible for the Central Health retirement and deferred compensation plans. Now, Jeff, take it away.
Okay, thank you. As I was mentioning, there is information related to this item that's included in the board packet. Staff is requesting that the Central Health Board of Managers approve naming a retirement investment committee to oversee the employee retirement and deferred compensation plans. The committee would act in the roles of both fiduciary and plan administrator. The committee itself will be chaired by our Vice President of Human Resources. Vice Chair would be the Central Health CFO. Benefits Administrator would be Secretary. And then we would have one employee representative from each entity of our enterprise. So that would be Central Health, Sendero, and Community Care. And again, they would act and make decisions in the capacity of administrators and fiduciaries related to administering the plan. So I'll be more than happy to answer any questions related to this item.
Thank you, Jeff. I think this is in line, in fact, what is more typical and what I see in other organizations. So thank you for bringing this forward. Members, any questions at this time? Not seeing any. Manager Jones, do you have a question?
One quick one. How have we been addressing this now up until now?
Budget and Finance Committee, right, Jeff?
Yes, that's correct. Budget and Finance Committee has been serving in that role.
So they would replace them on these items.
That is correct.
Okay.
Anything else, managers? Okay, we do need to have a motion on this item. Manager Valadez, you're on mute.
I don't have the motion sheet in front of me, but I'm moving.
Who has the motion in front of them?
I'll second Dr. Bell's motion.
I move that the board approve revisions to the plan, fiduciary and administrator designation, and renaming of the committee responsible for the Central Health retirement and deferred compensation plans as recommended by staff.
Yeah, try to say that 10 times rapidly, right? Okay, we have a motion by Manager Bell. Is there a second by Manager Valadez, correct? Any discussion? Seeing none, all in favor, vote aye.
Aye.
Aye. Opposed, same sign. Any abstaining? Thank you, members. The motion passes. We will now move to item number 9, receive and take appropriate action on revisions to the Central Health policy on policies. Mackenzie Fraser will be presenting with the aid of Trelicia Brown from the Travis County Attorney's Office.
Thank you, Madam Chair. Hello, Board of Managers, and thank you for this presentation time. My name is Mackenzie Fraser, and I am your Compliance Officer. Tonight, I would like to highlight and seek your approval on CMP 0011P, which is Central Health Policy on Policies and SOPs. Before jumping into the policy, though, I would like to remind the body, in overseeing a compliance program, as the compliance lead, I must ensure that our compliance program not only aligns with our needs, but our program must align with industry standards. In our space, there are 7 key elements or industry standards that must be in place within an organization to ensure its operation and supporting compliance program is effective and efficient. The element of focus tonight is implementing written policies and procedures and a standard of conduct. To support and drive this element, before you should see policy CMP 0011P and the applicable attachments. Attachment A, the policy template, and attachment B, the SOP template. Some significant changes to note within the policy, and please stop me if there are any questions. Within the header, the policy and procedures will now contain a review date. On down in the policy, at the top of page 3 or 4, the Compliance Committee will have a line of sight to ensure adherence to this policy. and of utmost significance, all central health policies and procedures will be reviewed at least annually, but no later than every 2 years. For the applicable attachments, the templates now include an option for enterprise awareness. So with that, to further support the consistency, culture, and transparency of our operational arms and the compliance program, tonight, I would like to seek approval from you all to operationalize these documents as to how we as Central Health will oversee the creation and how we as Central Health will oversee how policies and SOPs will be created and overseen. Thank you.
Thank
Are there
you.
any questions?
Thank you, Mackenzie. Any questions, managers? Certainly necessary, and we appreciate your work. And thank you, Tralisha Brown, for being here from the Travis County Attorney's Office. If there are no questions at this time, then we do need a motion.
Dr. Bell.
Manager Bell?
I move that the board approve revisions to the Central Health Policy on Policies and Standard Operating Procedures Management Policy, parentheses, number CMP-0011P, in parentheses, and as stated in the staff presentation.
There has been a motion. Is there a second? Manager Brinson, are you trying to say something? Okay, so there's been a motion by Manager Bell and a second by Manager Brinson. All in favor say aye. Aye.
Aye.
Opposed, same sign. Any abstaining? Thank you, managers. The motion passes, and thank you for this important work.
Thank you, managers.
We will now move to agenda item number 11, receive and discuss updates on the Central Health Enterprises responses to the current COVID-19 pandemic, including basic reports on services, coordination, and outreach with and among Central Health, Community Care, and Sendero Health Plans, Inc. Presenting will be Mike Giesland, Dr. Mary Carol Jennings, Tara Trower, Ted Burton, and Sarita Clark Leach. Thank you. I'll turn it over to them.
Thank you, Madam Chair. Members, tonight we'll have an enterprise COVID pandemic response briefing focused on areas, so it won't be as broad maybe as past briefings, but really focusing on certain areas of operations as well as some data points. First, we'll hear from Sendero, and then we'll move to Community Care. And then if, Tara, if you can hand it off to Ted Burton, and we'll pick up the Central Health update. Dr. Jennings.
Sure, mic check, everybody can hear me? Great. Thank you, Madam Chair, Board, for the opportunity to brief you on COVID for Sendero. I'll just take a few moments here. As I noted in June, our raw case counts create an epidemic outbreak curve that mirrors that of the larger Travis County COVID-19 infection rates. Here in this graph that we've highlighted, we segment our Sendero's COVID cases into orange, which represents general non-CHAP expansion members, and into blue on the bottom of each bar, showing cases among the CHAP expansion population. Since the beginning of the pandemic that you see throughout this chart, we've captured data showing a total of 531 members with a COVID diagnosis from amongst our membership in those 2 years. And as a note, this graph was prepared August 11th, so represents only the first week or so of August data. Side note here, members of our flagship CHAP program, which I'll remind you are Sendero's partnership with Central Health, which works to close gaps in our local healthcare safety net for our highest risk, most socially, medically complex members. Those memberships represent approximately 1 out of every 10 of our overall membership, varying a couple, percent or so on a given year. And since the pandemic began, something we wanted to just point out, we found kind of notable about our data is that our CHAP members account for approximately 1 out of 2 of our hospitalizations. Total hospitalizations that we've been counting with claims and case management, kind of live reporting from our active outreach, are around just a little over 60. And we also see half of our ICU admissions amongst the CHAP population. At face value, these sound like high numbers, but we would say that this or even higher rates than we see here are what we would expect, given how at risk these members are, how really vulnerable they are from our community. And my takeaway here is that this demonstrates one of the value adds of the CHAP program and ensuring that our sickest and most vulnerable don't have to think about bankruptcy, don't have to face financial troubles to be able to afford the care that they need. And sometimes it's really, really intense, really high intensity care, even in unusual times such as a pandemic. Back in June, just to refresh the board, I had reported post-intervention fully vaccinated rates among segments of our population of ranging from 56% in our under 65 non-CHAP medical risk factor population to 75% among our CHAP population to 81% of the over 65 not counting CHAP. And a takeaway from our programmatic data, our claims data, that we continue to see slow but sustained increases in our vaccination numbers of each of these segments. Another takeaway is that case management our lovely case management team continues to outreach all of our members when we hear of a new COVID-19 hospital admission, as well as any members who test positive, regardless of hospitalization status. And what we're doing there is ensuring that they know how to access telemedicine services should they decompensate or get really sick in the middle of the night, so they know how to get care without having to go to the urgent care or emergency care if it's not indicated. And also we help any of their family members get testing or help them get to vaccination sites. We actually get them there if they're not yet vaccinated and that's indicated. In June, I also looked ahead to continued partnership with our partners across Central Health, as well as with Dr. Walks and her team at Austin Public Health. And I want to highlight just a few of these partnership activities that we've seen start to get off the ground since then. They largely fall under our member services department, where we have allocated staff to collect survey data with Austin Public Health at a number of COVID vaccination clinics, to staff the Central Health's back to school event on the 14th of August, where backpacks and vaccinations were distributed, people were vaccinated. And we've been moving up kind of to respond to the current surge, moving up our distribution, which had been planned for a little later in the fall, moving up our distribution of care kits to send to members. And then finally, we're planning Sendero's Boo the Flu and COVID-2 fall vaccination event, October 23rd, in partnership and really solid partnership this year with Austin Public Health, who will procure and administer vaccines. They're estimating 800 flu vaccines and 500 COVID vaccines. So more to come on that. And with that, I thank you for the opportunity to report back to you and yield the floor to Ms. Trower for community care.
Thank you, Ms. Trower.
Thank you so much, managers. Thanks for the opportunity to speak with you. My name is Tara Trower. I am the Chief Strategy Officer at Community Care. Normally, Jason Fournier, our CEO, would be speaking to you, but he is in Wisconsin with several of our other team members doing a deep dive on electronic records management. First, I'm going to talk a little bit about our patient population and vaccinations. We've been very, very busy, both at the convenient care locations and our primary care clinics. This is different than the first phase of the pandemic with this surge. If you recall, we had fewer people coming in for other services. Things were sort of shut down. So at this point, we're managing many sick patients coming in with respiratory illness, not just COVID, RSV, and the appearance of what might be an early flu season now that folks are socializing again, as well as this surge with the Delta variant. Vaccinations did increase after a lull. You'll see the numbers in June. We had to pull midway through August. Things picked up in late July, increasing in August, and at August 17th, we appeared to be on track to outpace the vaccinations that we were doing in July, in part because of concern around the surge. We also had a number of events coupled with back to school where we did offer COVID vaccinations as well, where we were able to get some more folks. Just demographic wise, vaccinations are still proportionally more female. With our population, Latinos make up a huge amount of the folks that we are vaccinating. And then if you look at the age breakdown, we are getting to that 18 to 34-year-old population, which is being affected by the surge. The last thing I'll point out on this slide is just sort of our top locations. We are giving vaccinations at all of our primary care locations, but these are sort of our top performers with Rosewood, Zaragoza, North Central, and then Southeast Health and Wellness sort of in our top 3, and the rest kind of fall off after that. I will mention and kind of shift to sort of our community vaccinations. So we've got our patients, and then we've got the vaccination clinics that have been open to the community, which have shifted around over the summer based on need and demand. And one of the things that we've been addressing is the increased need for testing, and those are the same teams. And so really trying to balance our approach and get both testing and vaccination where it is needed. So speaking of community testing, we did restart community testing in mid-July based on demand at Hancock. We've got a capacity for about 50 a day, although we can do 60 under some circumstances. In talking with our nurse manager at Hancock, our positivity rates used to be around 6 a week, and we're now at 6 to 12 a day. I did add an extra slide if you could forward one. Just, I wanted you guys to be able to take a look at the positivity rates that we're seeing. And if you look at this slide, what you see is that in June, although there was some variation between our various demographic groups, go back please. Can you go back to the previous slide with the positivity rates? Thank you. You'll see that they're very, very close together. One more. Back to positivity rates. Anyway, what you can see on that slide right there is that the disparities really sort of hit hard when we get into August, where you see positivity rates for African Americans at 19.8%, positivity rates for Latinos at 27.7%, and non-white Latinos at 14.9%. Folks are getting sick, but it is disproportionately affecting the communities that we have had trouble getting vaccinations and convincing folks to come in terms of hesitancy. We are doing a lot more tests. We've had 123% increase in the number of tests from June to August, which really amounts to, we're completing about 127 tests per day. Which is nearly the same number in the first half of August as for the entire month of July. We expect that to increase as we go into the school year, with both folks experiencing illness and those trying to get tests in order to leave quarantine or exposures based on sort of the school environment. We are preparing for the 3rd dose and booster protocols, which I know that you guys have heard about, with CDC approved earlier this month, and then the FDA giving full authority, removing the emergency label off the Pfizer vaccine. We've got some time. Most of our patients, when we think about what we did at CODA, the big bolus of patients who will be eligible for that booster, we've got a few weeks to sort of plan how we're going to handle that. Vaccine is much more widely available in our community, but we are making plans and looking at standing up Rosewood, Zaragoza as a vaccine site. And with that, I spoke very, very quickly. If you guys have, I'll open it up for questions.
Manager Valdez, do you have a quick question? Because I think we may want to, actually, let's hold those questions. I want to continue through the presentation if we could.
I'm sorry, I thought it was through.
Thank you. I'll pick it up. Thank you, Tara. This is Ted Burton. I'm Vice President of Communications here at Central Health. It's good to see everybody this evening. I want to briefly talk about our communications and outreach efforts over the past couple of months. Excuse me. Mike mentioned earlier in our budget presentation that we sent another direct mail piece out last week to 32,000 MAP households. Since last year, April of last year, we have now sent out nearly 200,000 postcards in English and Spanish to MAP households in our community. All but one of those were focused on, all but two of those were focused on vaccines and COVID preventions and protocols. One was regarding the census and one was regarding promotion of the Hornsby Bend Clinic. We are working, an important milestone is we are working in collaboration on a unified marketing campaign with Central Health, Austin Public Health, and Travis County. I'm pleased to announce that all three entities are contributing in some way or the other for our comprehensive campaign under our Let's Stick Together umbrella message. It includes television, digital, online, radio, social media, and other tactics. And I think one of the most important parts of this campaign is not the fact that everybody's contributed to it, whether it's financially or creatively, but also that we're using the same message, same look and feel. And we're in market now, beginning this week with promotion of vaccine pop-up events. Next slide. Our business, faith, community, and apartment complex outreach continues. Since August of last year, we have personally visited, with the help of our consultants, Community Coalition for Health and Latino Healthcare Forum, more than 1,100 locations, delivering PPE, posters, flyers, etc. We have focused on 10 high-risk zip codes, and we recently delivered educational posters to 221 locations. As Mike mentioned, we have hosted virtual town halls with faith communities. We hosted 5 town halls, 4 with African-American churches and 1 with a Spanish-speaking Latino church. And through those town halls, we had nearly 4,000 views. And finally, under the direction of Elizabeth Moretto, we have been helping Travis County staff their pop-up events at the JD's supermarkets, 3 a week, so Tuesdays and Thursday nights from 5:30 to 7:30. We've distributed more than 1,300 gift cards to people who are getting a vaccine. These are $25 gift cards. So each gift card represents a vaccine. So that program has been very successful as well. And with that, I do not recall to be honest.
I think we turn to Mike Giesland now.
There we go. Mike with more on the equity incentive program.
Yes, thank you very much. And thank you, Ted and Tara and Dr. Jennings for those presentations. Members, right now we're going to focus on our vaccine initiatives. We spoke of these earlier in the year, and there was a two-pronged approach to this. One is how can we create an incentive payment program to foster the equitable distribution of the vaccine through the federally qualified health center partners, and predominantly community care delivering the vast majority, but also working with Lone Star Circle of Care as well as People's Community Clinic. And again, relying on that provider-patient relationship to try to encourage equitable distribution of the vaccine, especially in high risk and socially vulnerable zip codes. The second approach to this was not on the provider side, but on the vaccine taker side, the patient side. What can we do to incent taking the vaccine? So that was the overall strategy. And what we're trying to do with these, not only is have real-time impactful programs out in the community to encourage vaccine and to also ensure that individuals in high-risk zip codes and that the margins receive that vaccine, but also to test some hypotheses so that we can learn, because this is going to be with us for a while. So what can we do going forward? And with that, I will turn this over to Sarita Clark-Leach, who will walk us through some key data points.
Thank you, Sarita.
Great, thank you, Mike, and good evening, managers and leaders. So as Mike indicated, if you wouldn't mind going back to that slide that Mike was just on. Yes, great. So he mentioned that there were 2 incentive programs, and one was to incentivize providers, the other patients, to receive the vaccine. And for that first program, the Equity Incentive Payment Program was meant to incentivize providers to vaccinate those folks who were Central Health patients, and 2 who resided in a zip code that was identified as a high-risk zip code in terms of spread, and also in terms of having a large proportion of the population who were disproportionately impacted by COVID and in terms of hospitalization and death. So this program, what we measured here was from March 1st through July 31st of this year. Participating providers were community clinics, Lone Star Circle of Care, and People's Community Clinics. Those providers expanded hours, extending them into weekend and evening hours. They added upwards of 8 vaccine sites, and within those target zip codes, increased staffing, increased outreach to those zip codes as well, in order to ensure that we were targeting the right population. We were really getting our members who may not present for whatever reason to come in and get vaccinated. Payments were made for each vaccine administered, as I said, to Central Health patients and to anyone who resided in one of 20, really 19, because one included a zip code that we used to identify our homeless population. But in 19 zip codes predominantly, again, on the east side, a lot in that central corridor where a lot of our MAP and MAP basic patients live, as well as other low-income areas. So a total of about 50,000 folks were vaccinated through this program at a cost of a little over $314,000 to Central Health. And there was a $450,000 NTE for the total program overall. For the gift card incentivization program, the dates we have for that are June 19th through August 6th of this year. Patients were given $25 gift cards when they presented to one of the pop-up vaccine events, and they were receiving their first vaccine dose. And it was done in partnership with Travis County Mobile Vaccine Collaborative and Austin Public Health. 1,342 people were vaccinated. About five of them refused the gift cards, and that came up to a cost of about $34,150 for all of the cards purchased. And next slide, please. In terms of how this broke down, relative to the patient population, for the equity incentive program, again, that's the providing incentive to the providers. We have about 50,000 people vaccinated. Of those, about 64% were people of color, 54% female, and there was more or less an even distribution of vaccines among people aged 25 to about 60. And 74% of those vaccinated through that program resided in Eastern Travis County in those 20 subset I mentioned. And I'll show you a map later to show you how it breaks out. For the gift card incentive program, we had 1,342 people, as I said, who were vaccinated, and about 97% of those people were identified as people of color, with 90.7% of them being Latino. About 60% identified as male, which is a really high skew to the male population. And then the age distribution, again, it's skewed heavily towards children, pediatric population. And so kids between the ages of 12 to 20 represented over a quarter of the population who were vaccinated. And again, 81% of those people vaccinated resided in Eastern Travis County zip codes. And here is the demographic breakout of the combined population of about 51,321 folks who are vaccinated. And you'll see again, in terms of race ethnicity, about 64% vaccinated were people who identified as a person of color. And then looking at a map here.
We're not getting those sheets.
Oh, I'm sorry. Can you go to the next? There we go. So those are your demographics breakouts. And then if you go to the next, And here's your the map, and you'll notice that the hash marks on the map represent the 20 zip codes that we wanted to incentivize those vaccinations to happen in. And you'll notice that, you know, the darker colors, the darker color gradient represents higher volumes. And you see that the majority of those folks who are vaccinated did reside in those zip codes. So thinking about the takeaway from all of this, presumably the funding from the Equity Incentive Payment Program is what allowed providers to add vaccine locations and targeted zip codes, make vaccines available after hours, and increase staff for the vaccine effort. For the gift card incentives, the impact is it's not as easy to determine at this time. We conducted an intercept survey that indicated that people who presented to the vaccine pop-up events were primarily because they knew that the vaccine was tested and safe, free, and it was now convenient for them to get that vaccine. As you know, they were allowed to walk in, didn't have to go to sites and register, et cetera. And that they had friends, family members, and coworkers who got the vaccine. Only 7% of that population explicitly stated that they presented because there was a gift card available. And also if we decide that we do want to continue the program, we'd have to make sure that we're coordinating planning efforts so that we're not competing with other vaccine incentive programs such as Austin Public Health's $50 vaccine giveaway to folks who come in to get vaccinated. And that is all I have for you today.
Thank you. Does that conclude our presentation? Mike Giesland, anything else?
Yes, it does. At this time, we're happy to answer any questions.
Okay, members, I'm going to take Manager Musaitov and then Manager Valadez. And then if there are others, we'll go in order. Manager Musaitov.
Thank you. Thank you for the presentations. One thing that came up, the first slide, the Sendero case review, was there a typo in June? That was one. And Ted, your terms of your outreach, have you reached out to any mosques? You didn't mention any of that. I know the.
Okay, so we're going to the slide first. Let's look at that. And then Ted, if you can answer the question regarding mosques and outreach. Let's look at the slide here.
78. Is that a typo there?
Which one?
The graph 78 for June 2021. What does 78 represent here?
Oh, that must be a typo. Mm-hmm.
Okay, because I'm like,
yeah, the numbers will add to it. 8.
We have that many cases. Okay.
Yep.
Thank you.
Good catch. Thank you. Ted, has there been any outreach to mosques?
Yes, I can look at our spreadsheet and get back to you. I don't know for sure off the top of my head. I'm happy to look. We have a robust spreadsheet that I will check.
Okay, thank you. Thank you, Manager Musaitov. Manager Valadez.
Yes, I just would like to know if y'all can give me, thank you, Tara, Sarita, Ted, and Dr. Mary from Sendero. If y'all can give us an idea as to how you're rolling out or how quickly the public will be notified about where they can go for their boosters, especially our CHAP members, our MAP Basic members, and our medically needing and fragile.
Okay, so question regarding seeking boosters. Who can respond?
And I guess before we get to the boosters, the vaccinations, are not our CHAP members or MAP members getting vaccinated?
Okay, so the first question is regarding vaccination of CHAP and MAP members, and then the second question is boosters. Who can respond to that, please?
Thank you, Sherry.
You're welcome. Thank you.
I can talk briefly about the communication side, and Tara may want to step in.
Thank
but
you.
We are working with Community Care, following their lead to roll out messaging about the third dose. We've already sent information out based on what Austin Public Health has been saying, but we want to specifically focus on obviously our MAP members and community care patients. So Tara and her team are I believe as soon as they have Epic secured, then they'll have some more formalized messaging for our MAP and community care patients. But Tara may want to weigh in.
Sure. So yes, in terms of the third dose to get that group who's immunosuppressed to immunity, we are following CDC guidance. In some cases, patients who have doctors who are treating those spelled out conditions, they're presenting those, and those folks are getting vaccinated. The EPIC issue to which Ted speaks has to do with the boosters, which we've got a little more leeway. Not many people are at that window just yet, but we are working to make sure that we've got templates so that the physicians and providers know what to do when folks arrive, so that we can roll that out, and we anticipate having that and additional guidance out in the next week or so.
Thank you very much. And
thank you. Members, are there any other questions at this time? Yes, Manager Jones?
Yes, just quickly, could you go back to slide 2 of community care, the one that talks about ethnicity? I didn't see perhaps I missed it, but I just saw ethnicity. I didn't see a racial breakdown.
I can give you those. I ran out of room on the slide and I was asked to only do one, and I gave you all 2. So African Americans, this is for vaccination. African Americans were at 7%, with 18% not reporting race at all. And then 3% Asian American and Pacific Islander.
Okay,
Thank you.
Thanks very much. I didn't see that. That's why I was.
Thank you. Okay, managers, anything else? If not, we are now moving on to
one last question.
Yes, Manager Musaita, please.
That's probably more directed to our CEO, Mr. Giesland. Are you now requiring Central Health staff to be vaccinated, given the approval of FDA Pfizer vaccine? So if you can give us your input where you stand there.
Yes. So we've had a large all staff meeting, and I've also had some individual group staff meetings to start socializing this issue of requiring the vaccine, but also providing incentives to take the vaccine, providing a benefit for taking the vaccine. Now with the change in the Moderna status, with the emergency use authority being lifted.
You mean Pfizer status.
Thank you for
Moderna
correcting
to come
me.
soon.
Pfizer,
Yeah.
not Moderna. Hopefully, knock on wood, Moderna soon. They're hereafter. But working with Susan Willers and Dr. Shalsha and others to create a policy where we could mandate vaccines. But this is not formal. I'm answering your question openly and honestly, but there's a lot of communications that need to occur, through proper HR channels with staff, but also giving ample time to get the vaccine if they haven't gotten it already, but also to look at how we would handle and process requests for accommodations for those that cannot receive the vaccine. So there's still a few more pieces we have to put into place, but yes, that is under consideration.
So to answer your question, Manager Musaita, we are working on this, and Mr. Giesland, as he said, is being transparent. We are working on this, and there will be more forthcoming. Thank you.
Thank you. Thank you, Mike.
Other questions at this time? Seeing none, we will now move to agenda items 12 and 13. Agenda item number 12, receive and discuss updates on the 1115 Medicaid waiver delivery system reform incentive payment, open paren, district close paren program and associated projects, the Community Care Collaborative and other healthcare delivery partners, programs, projects, and arrangements, including agreements with Ascension, Texas. Also, agenda item number 13, receive a briefing regarding Central Health Enterprise Information Security. I announce that the board is convening in closed session to discuss agenda item 12 in closed session under Texas Government Code section 551.071, consultation with attorney, and agenda item 13 in closed session under Texas Government Code section 551.089, deliberation regarding security devices or security audits. So members, you should have received the link for the closed session. Please leave this link and go to the closed session link and I will see you there. Oh, okay. Managers, we have finished our closed session. There is no action or motions necessary. We are now back in open session. It is 10:08 on Monday, August 23rd. Managers, our next Central Health Board of Managers meeting is scheduled for Thursday, September 2nd, 2021 at 5 p.m. or immediately following the Executive Committee meeting at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment.
I move to adjourn.
We have a motion for adjournment. Is there a second? And yes, Manager Bell. So we have a motion by Manager Valadez, a second by Manager Bell. All in favor, say
Aye.
Aye.
opposed, same motion. Any abstaining? None. Thank you, managers, for a very productive
Thank you,
meeting.
members.
Bye.
Good
Good night.
night. Good
Bye,
night.
everyone. Bye-bye.
Good night.
Peace out.